Good morning everyone and welcome to the National Health Careers Conference 2023.
Hi, my name is Nat.
Hi everyone, I'm Amy Robson. I'm the Deputy Director of Personalised Care at NHS England. I'm a physiotherapist by clinical profession and working in this strategy and non-clinical role in NHS England nationally.
Hi there, I'm Dr. Freddie. It's great to see so many of you here at the Health Careers Live Conference 2023.
It's always a delight to meet with you, and I hope today's session will be useful.
Maybe you're attending today thinking, okay, I know I want to do this job in the NHS. It might be that your eyes are open today to some other options as well that look really exciting to you. Or you might have joined thinking, I want to work in health, but I've no idea what I want to do. So, for you, this day is perfect.
Why is diversity in healthcare important? And I just want to touch on three main things that I think are really important when we think of diversity in healthcare.
We know that GPs look different to people now. People perceive GPs slightly differently. You mentioned earlier about how the pandemic has had a huge impact on how we operate. We see that our patients are becoming more and more complex in the way that they present. We set ourselves a target to eliminate disproportionate referral and eliminate differential attainment in education.
To me, personalised care is both the middle of that continuum as well as the ability to meet the person where they are in that moment of time.
It's always great to be able to kind of open people's eyes to the range of roles in the NHS and the range of routes in, because there is so much more than you might be aware of.
It is inspiring to know that there are so many options to progress and to really put your passions across in healthcare. We're glad to announce that next year's conference, the National Health Careers Conference 2024, will take place on Friday the 5th of July next year. So please do keep an eye out over the next few months on our social media pages. Thank you very much for attending.
NHS England, and I'm just going to say welcome to Health Careers Live. Hello, I'm the Chief Nursing Officer for England. Welcome to Health Careers Live.
Hello and welcome to the National Health Careers Conference 2024. My name's David and I'm a final year medical student at the University of Nottingham and incoming F1 doctor at the Wessex Deanery. I've also been a member of Becoming a Doctor for over 4 years now, so it gives me great pleasure to introduce you to some of the exciting sessions we have planned over the coming hours. Please also check out the career pathways, which includes medicine, nursing and midwifery, mental health, global health and more. You can also find out all the details for the day on our programme. So for this morning's sessions, we have NHS Health Careers, that's just doctors and nurses, right? With Abigail Changer from the Health Careers team at NHS England. We also have 2 sessions from Tista Chakravarti Gannon from the General Medical Council, titled Collaborating for Compassion and A Paradigm Shift to Anti-Discrimination. Make sure you have your notebooks and pens because there's lots of great speakers and engaging topics to come. Join the discussion online using the hashtag HealthCareersLive. I hope you have a great day and learn something new.
Good morning, everyone, and welcome to this day. It's a real privilege to be the first speaker on this event today, and it's the NHS anniversary as well, 76 years today. So really great timing as well to celebrate the NHS. And what I'm hoping to do in the next half an hour or so is to give you an overview of careers in health, talk about some of the routes in, talk about how you can go about finding out more, and answer some of your questions. So my name is Abby. I'm from the NHS Health Careers team in NHS England. I've got a long NHS history, starting off with being a nurse back in the 90s and have done several jobs in the NHS since then. And I'm now, as I said, part of the careers team, which is a really exciting area to be working in. So I'm going to share some slides with you now. Oh, they're already up there. Brilliant. So the title is, NHS Health Careers. That's just doctors and nurses, right? Because there is a bit of a narrow view sometimes of the roles that we've got in the NHS. And so part of what I want to do in the next half an hour or so is to kind of open your mind maybe to some of the other options. It might be that you've come here today with a really clear idea of what you want to do, and that's fine, that's great. Some people have got very clear plans. Or you might be sitting here thinking, well, I know I want to work in health, but I don't know exactly what I want to do. And so hopefully this session and the rest of the sessions today will really help you start to do some more exploring, to get inspired, to ask questions, to find out more, and to perhaps start to get an idea of where you might go next, because there are over 350 different roles in the NHS. So there is a lot to kind of think about. The common thread between all the roles in the NHS is that they all make a difference to patients' lives at the end of the day. So whether you are that nurse providing the hands-on patient care in the emergency department, or you are the paramedic attending a serious incident that's happened somewhere, or you are looking after the grounds of a hospital, or you are a maintenance engineer in a hospital, or a healthcare scientist, whatever your role, you are making a difference to people at the end of the day. And I think that's a really important thing to hang on to. One of the other myths that we sometimes come across is that you've got to have a degree to work in the NHS, and that's not true. There are so many different routes in. Yes, there are some roles where you do need a degree. So if you want to be a doctor, you've got to get a medical degree. If you want to be a nurse, you've got to get a nursing degree. but there are different ways of doing that, and there are lots and lots of roles. There are entry positions, there are ways of moving and progressing your career without having to get a degree necessarily. So we'll talk a little bit about that today as well. And if looking after patients hands-on is not your thing, then that's fine too. There are loads and loads of roles that are more behind the scenes, but where you are still, as I said, crucially making that difference. So we're going to talk about some of the careers that are available, how you can get in. We'll talk about some of the financial support, particularly if you are wanting to head to university. And then I'll show you some resources that you can go to find out more, and also show you the NHS Jobs website. And we will have time for questions at the end as well. So please do put your questions in, and I'll try and answer as many as I can in the time that we've got. Okay, so the first thing I want to say, just to, again, part of the setting the scene, is that the NHS, although we've got kind of this umbrella organisation of NHS England, it delivers its healthcare through hundreds of separate employing organisations. So each NHS trust is an employer in its own right, GP practices, all the different bits of the NHS are their own separate employing organisations. And the reason I'm telling you that is that each one of those will be responsible for its own vacancies, it'll have its own workforce priorities, it'll have its own work experience programmes, it'll have kind of differing levels of apprenticeship opportunities. Some NHS organisations are very active in terms of kind of school and college liaison activity, others might be less so. So it can really vary. The other thing we sometimes see is that different trusts might call the same or a very similar job different job titles. So if you're starting to look for a job or an apprenticeship, then it's really important to use some different search terms, and we can talk a bit more about that as we go through. Okay, so this is quite a busy slide. What sort of careers are there? This is how we categorise the careers in the NHS at the moment. It's not a perfect categorisation, but it's what we work with at the minute. And you'll see on the Health Careers website, which I'll show you later, how the Explore Roles section is broken down using these particular headings. So just to very briefly kind of talk you through some of these, we've got the allied health professionals first, and they are a really large group of staff in the NHS, and I'm pretty sure you've got some sessions on these later. So this includes roles like paramedics, radiographers, speech and language therapists, occupational therapists, podiatrists, prosthetists and orthotists, and many, many others. There are 15 different roles in the allied health professions. Many of them are really focused on enabling people to live as full a life as they can within maybe constraints of a disability or a long-term condition or after surgery, things like that. And there are often opportunities to specialise in working with mental health or with children, or in different settings in the community, or in more acute settings in hospitals, for example. So that's the allied health professionals. Have a good look on the website if you want to find out more about them. Then we've got the ambulance service team. So this isn't just about the paramedics, but this is also about the people more behind the scenes roles, the call handlers as well, but also the emergency care assistants working on the ambulance, the patient transport service as well, the non-emergency side of lots. Oh, I seem to have been, was I muted then and unmuted? I don't know what's going on. Hopefully you can hear me. And we've got the dental team as well. So again, more than just dentists, there are dental technicians, hygienists, dental nurses, technologists as well. So quite a large group of staff there. Doctors, we've all heard of doctors, and I'm sure a lot of you here today will be here because you want to find out more about getting into medicine and the many different specialties there are there. Estates and facilities, this is a really important group of staff. So in here, we've got people like mechanics, carpenters, but also crucially and becoming more and more prominent are the roles related to kind of green careers and environmental sustainability and reducing carbon emissions and that kind of thing. So there are an increasing number of roles in that sector if that's of interest to you. And we're seeing some hybrid roles as well, where people are working in clinical roles. So for example, I not that long ago, as part of an event, met a nurse, an intensive care nurse, who is also involved in the green agenda and looking to for ways to reduce waste and that kind of thing in the work that she does. Health informatics, another really growing area, so digital data and technology roles. So as you would expect in the NHS, we are moving with the times in terms of technology, and we're going to need more and more of these people who are really comfortable with data and digital. We need cybersecurity professionals. That's something that often people don't think about when it comes to the NHS. But when you think about the data the NHS holds, there's a lot of data, it's sensitive data. We need those people working in that field. Healthcare science is another area that perhaps not a lot of people know a huge amount about. So you might think about the roles that are very laboratory based, and there are some roles like that, particularly when you think about biochemistry, but we also have patient facing roles in healthcare science. So cardiorespiratory specialists and sleep specialists as well, neurophysiologists, lots and lots of roles where you can combine that love of science with a diagnostic and treatment side of things, but in a healthcare science role rather than kind of medicine or nursing. Management, we need lots of types of managers, finance managers, HR, estates managers, strategy, project managers, you name it, there are lots of opportunities there. The medical associate professions, this is a pretty small group of staff, so it includes roles like physician associates, anaesthetic associates. And midwifery, we've all heard of midwives, but we've got the maternity support workers as well, working and supporting the midwives in what they're doing. And then nursing with its 4 different fields, so adults, children's, learning disability and mental health nursing, with numerous routes to get in and lots of opportunities for expanding and progressing careers there. And then pharmacy. So again, it's not just pharmacists, but you've got assistants and pharmacy technicians as well, and various routes in. And the psychological professions also expanding massively. So, you know, we're all aware of the mental health challenges that so many of us in our society face. And so the psychological professions are both expanding in number and in types of roles as well to be able to provide the support that's needed. Public health roles too. So again, some of these are based in local authorities, some of them are in national roles, some are within the NHS, and this includes roles like school nursing as well as those people that are looking for ways to protect our wider society and to maximise health within our communities. And last but definitely not least, the wider healthcare team. So this incorporates many, many different roles that are as important as all these others and all work together to make the NHS function well. So that's a bit of a kind of a gallop through those categories, but hopefully it's just giving you a little bit of a taste and you can go away and find out more if you want to. So I just wanted to give you an idea of a few of the roles that might appeal to you depending on the sort of thing you want to do. So if you're a very hands-on person and you really enjoy, you want to use practical skills in your work, then I've just pulled out a few examples of roles that might interest you. This is not an exhaustive list, okay? It's just a few things to get you thinking. So I won't read them all out, but roles such as clinical photographer or emergency care assistant, IT support engineer or prosthetist, so that's someone who helps to develop prosthetic limbs, for example, for someone who has lost a limb or perhaps been born without one. So lots and lots of different opportunities there if you're a very hands-on person. Or maybe you're really keen to work with children and young people and support them in some way, maybe in a psychological profession or as a health play specialist, newborn hearing screener. Again, lots of different roles there. It's not just about being a children's nurse or a paediatrician, but there are many different ways to do that. I'm sure a lot of you here today are here because you love science and you want to use that in a way that helps people and makes a difference to lives. And again, just a few examples here. Obviously, there are endless examples of roles within the NHS where a science interest and skill set is really, really important. Okay, so I mentioned earlier that there are lots of different entry points, and I kind of think of it as a little bit like a tube line in London, where you don't have to get on at one end of the tube line and travel all the way to the other end on the same line. You can hop on at different points, you can change lines, you can do different things. And I think that's one of the brilliant things about the NHS is that there are so many opportunities, and I've done this in my own career where I've moved sideways sometimes and then up and tried something different and taken opportunities as they've arisen. I haven't been on a kind of set path as such. For some people, they've got a really clear plan, and that is great. And there is nothing wrong with that, but there's also nothing wrong if you don't have a plan. Okay, so never panic, never think that you've closed off doors by choosing one set of A levels over another, because there will always be a way to get to where you want to go. It might take a little bit longer, it might be a little bit kind of wiggly and wavy, but that doesn't matter. It won't be wasted experience along the way. So we'll talk about work experience a little bit later on, but you might want to get into volunteering. That might be your entry point into the NHS. There are entry-level roles. So there are roles that even if you don't achieve maths and English GCSEs, you can get a role and get supported to gain those qualifications as part of your role. There are apprenticeships available. There are some roles, as I said, where you need a degree, and there are some roles where you need postgraduate training as well. Clinical psychologist, for example, you need to do a degree and a postgraduate qualification. And some people come into the NHS having gained experience in other sectors, and they bring transferable skills and life experience with them. So there are no right or wrong ways, and just kind of highlighting the different ways you can get in. Okay, I had a look on NHS jobs in the last week or so, and these were some of the live apprenticeship vacancies that I found. Again, this is just to give you a little bit of an idea. I just pulled out a selection across the country, and I'll let you have a bit of a look at the range there, because we've got everything there from junior data scientist to a psychological wellbeing practitioner, ambulance service call handler, content creator. Had you thought about that there'd be content creators in the NHS? So just giving you, as I said, a bit of a flavour of the range that's out there. So these are apprenticeship opportunities that have been live very recently. Excuse me. Okay, in terms of degree level apprenticeships, these are apprenticeship standards that have been approved for delivery. But what I want to make really clear, just to kind of manage people's expectations, is that just because these have been approved for delivery, it doesn't mean to say we're seeing lots of vacancies at the minute. We do expect to see an increase in the number of apprenticeship vacancies in the coming months and years. But it is possible to become a registered healthcare professional in these healthcare professions by doing a degree level apprenticeship. So you'd get paid while you're doing it. You don't have tuition fees. That's all taken care of for you. And you'd be getting that hands-on experience while you're doing it. Apprenticeships in the NHS are advertised on the NHS Jobs website. But we do say if you can't see what you want in let's say you're looking in your local NHS trust for a registered nurse degree apprenticeship and you can't see one, get in touch with the apprenticeship lead at your local NHS trust and see if you can find out if they've got apprenticeship opportunities coming up. Or consider getting in at a more entry-level role where you can start to build your experience and you've got a foot in the door, you're in place then if an opportunity becomes available. In terms of going to university, and a lot of you might have joined today and that's your plan, you're off to university, you want that experience, then these are the healthcare degrees that are available at university, the clinical ones. And there are also a number of these that attract some funding, which is good news. So there's something called the NHS Learning Support Fund. If you're studying nursing or many of the allied health professions that I mentioned, or midwifery, if you're eligible for student finance through Student Finance England, you'll be eligible for the NHS Learning Support Fund, which gives you £5,000 a year that doesn't need to be repaid. Okay, it's not a loan, it's a grant, and that's to help you towards your living costs. There are also some extra bits to that. So there are some specialist subjects that are harder to recruit to. So mental health nursing, learning disability nursing, radiography, podiatry, prosthetics, orthoptics, and you'll get £6,000 a year if you're studying one of those, which is great news. And also if you're having to travel to clinical placements, then you can get some help with travel and accommodation costs as well. The NHS Business Services Authority is the organisation that administers that, and you get paid in termly instalments, I believe, across the academic year. Also, if someone has done a degree already in something else and then decides they want to retrain in a healthcare profession, healthcare degrees are a bit different to other degrees in that usually people can get a second round of student finance. So that's just worth bearing in mind as well, that there are exceptions made for many healthcare degrees. Medicine and dentistry degrees have slightly different arrangements, are quite complex. I'm not going to go into those in detail now, but you can find out information on the Health Careers website if you want to have a look. Okay, I wanted to give you some example apprenticeship pathways. So for those of you that are thinking, I'm not sure university's for me, it's not quite what I want to do, I want to get stuck into the workplace sooner, I want to start earning money, then these are some of the ways you can progress your career by doing a series of apprenticeships, because you can do more than one apprenticeship, one after the other. So you could, for example, start off in a healthcare science assistant apprenticeship at level 2. That's equivalent to GCSE level. You could then move on to a healthcare science associate apprenticeship at level 4. And then, if the opportunity was available, healthcare science practitioner, which is a degree level apprenticeship at level 6. And then you would come out as a healthcare science practitioner. Or perhaps if you say you wanted to be a therapeutic radiographer, you could start off as a healthcare support worker, level 2, then move on to the assistant practitioner, level 5 apprenticeship, and then the therapeutic radiographer degree level apprenticeship. And you've got exactly the same qualification and registration as if you'd gone to university and done therapeutic radiography at university. Just a couple of example routes into nursing. So you might have 5 GCSEs at grades 4 to 9. You could then potentially access the nursing associate apprenticeship, which is a foundation degree level apprenticeship, which would take 2 years. And then there are what are called top-up, so shortened registered nurse degree apprenticeships at level 6, which would take another 2 years and give you your full registered nurse degree qualification and professional registration. Or perhaps you've got GCSEs, you go and get onto the healthcare support worker apprenticeship, senior healthcare support worker apprenticeship, and then the registered nurse degree apprenticeship. So lots of options available, as I was saying, and that will partly depend on what's available in your local NHS organisations, but it's worth you knowing the possibilities are there. Right, work experience. I know that this is something that can be quite tricky to get, and it's something people really worry about sometimes. And my main message is please try not to worry too much, because employers and course providers do know that it can be really challenging to get face-to-face work experience in the NHS. So I'd encourage you to do several things. First of all, look to see if there are any really specific requirements for a course or a job. And that will kind of help direct you to the sort of thing you need to be looking for. Think very broadly. So it doesn't necessarily need to be experience in a hospital. Think about care homes. Think about charities. Think about GP practices. So, for example, in GP practices, they have something called patient participation groups. And if you're a registered patient at that surgery, you can join that group. Perhaps you can do a little project for that group, something like that. Think about volunteering. Think about what you do in your life outside school, college, whatever. Have you helped an elderly neighbour with shopping, perhaps? Even if you work in a shop at a weekend, that's delivering customer service. You're showing that you can work in a team. You're showing that you've got communication skills. You're able to demonstrate that you respect people and that you are compassionate to people. We'll talk about the NHS values in a minute and how important they are and all the different ways you can evidence them. So use examples from all areas of your life. Look online as well. There are an increasing number of kind of virtual work-related learning opportunities online. So get onto Google, have a look and see what's available. Some of it might only be available for people in your area. Some of it might be available nationally. So have a look and see what's there. But also do look at your local NHS organisations. They might have work experience opportunities there. Go onto their websites, put work experience or volunteering into the search bar and see if they've got a contact that you can get in touch with there. So knock on as many doors as you can, get as many different types of experience as you can, and don't get completely hooked on it having to be a face-to-face hospital work placement. There are lots and lots of different ways of showing that you're the right kind of person for a course or a job and that you've done your homework. Look in the media as well. There is plenty to look at in the media about the NHS. Find out what the current issues are. Find out what some of the plans are. The NHS has got a long-term workforce plan. Have a look at that and see what it says. So gather as much information as you can. Talk to people that you know that work in health. How did they get into their job? What do they love about it? What do they find challenging about it? Just absorb as much information as you can. And also, actually, just what I'd also say is it's about what you take from an experience. So even if you're offered a morning shadowing someone in a workplace, take that and have your eyes and ears open as much as you can. Write down what you've learned from it. What did you observe? How did you see the staff behaving? Did you see the NHS values displayed? So keep a log of what you're doing as well, so that you've got that evidence there. Okay, the NHS does something called values-based recruitment, and this is so important because we are looking for the people that have the right qualifications and experience. Of course we are, but just as importantly, we need people who hold the values that align with the NHS values. And the next slide will show you what they are. So if you want to join this team of 1.4 million that the NHS has, we want to make sure that you're the right kind of person for the job. You might get 4 A stars in your A levels, but you also need to be able to treat people with dignity and respect. You need to understand what compassion is and to be able to demonstrate that. So these are the values from the NHS Constitution, and these are just so important. So have a look at these and think about how, if I said to you, okay, tell me about a time when you've shown respect and dignity, make sure that you've got that evidence, you've got those examples ready. Think about what everyone counts means. What does that mean in that particular role that you want to do? What would that mean? How would we see those behaviours displayed? So really get yourself familiar with these. There are the 6 C's as well, and individual NHS organisations might have their own set of values. They're not going to be vastly different, obviously, from these main NHS values, but really get familiar with them and think about how you can evidence them, because it's really important. Okay, so onto some resources. This is what the Health Careers website homepage looks like. So this is the main NHS Careers website, healthcareers.nhs.uk. Tons of information on here. So we have got the Explore Roles section, we've got a course finder, we've got a Contact Us page, and our careers quiz. So if you are here today thinking, I'm not quite sure what I want to do, or I've got a bit of a plan, but I'm interested in exploring other things that might suit me, have a go at the Health Careers tool. So this is called Take Our Careers Quiz. You'll see it on the homepage of the website, and it's a series of statements. And then depending on how you respond to those statements, it will come up with some roles that fit your skills and interests. And then you can click into those roles and find out more about them. So I'd really encourage you to have a go at that. It just takes a few minutes. And it might bring up some roles that you've never even heard of or hadn't considered would suit you and give you some more ideas. If you are wanting to head to uni and you know what profession you want to do, you can use our course finder tool. This is under the career planning section. So this just brings all the courses together in one easy to find place, and then you can click through to the university website to find out those all important entry requirements. If you've already started doing your research into university courses, you'd have realised that entry requirements can vary quite significantly between universities. So it's really important to check out what they are on the different university websites. NHS jobs, as I mentioned, this is where you'll find adverts in England and in Wales actually for jobs and apprenticeships in the NHS. So there are lots of different ways of searching. You can search within a radius of a certain postcode or town, or you can use different search terms. And I'd really encourage you to try as many different ways of searching as possible so that you get the maximum number of search results and don't miss anything. You can also look for advice on here. So there is advice around kind of interviews and applications as well. So that can be really, really helpful. So that's where you'll find those job and apprenticeship vacancies. And finally, just kind of encourage you to ask questions, really. So please do ask me your questions today. We've got our websites and we've got social media, so you can direct message us on social media. I've put the various handles there, and also we have a contact centre, an NHS Health Careers contact centre, that you can use the contact us form on the website, or DM us on social media, or you can phone or email, and all the details are on the slide here. So I hope that's been helpful. I realise that is a lot of information there, but hopefully it's been helpful. And I hope there are some questions. So that's it in terms of slides. Yeah. Right. Okay. So we've got a question. Thank you. So what roles in hospital can you think of that don't need formal degrees? So it depends what sort of role you want. If you want a kind of a clinical hands-on role, then support worker roles don't need degrees. So you could be a physiotherapy support worker, for example, or a mental health support worker. There are lots of different options there. If you're thinking about medical laboratory assistant as well, on the non-clinical side, all sorts of roles. So IT support, there are communications and media roles, finance roles, admin roles, all sorts of things. Get onto the website and have a little look. And also, if you do the careers quiz, the first thing you'll see is that you select a qualification level that you want to have a look at, so you can see what comes up there. So I hope that helps. Okay, any more questions? Medicine, nursing, and a career in health, but not sure what yet. So just do an explore, have a look on the website. We've got some videos as well. We've got a YouTube channel. There are people talking about their roles. So have a listen to those, see what some of the opportunities are. There are so many different settings you can work in as well. It's not just hospitals, it's people's homes, prisons, education establishments, GP practices, so many different places that people in healthcare can work. So good luck making your decision, Charlotte. Are there any more questions? So someone here, we're joining from our Future Healthcare Professionals group at college. Brilliant, welcome. Glad you're able to come along. The session is going to be useful to learn more and for applications, definitely. So yeah, as I say, hopefully you'll find the information. If you look at the career planning section on our website, we've got application information there as well. So have a look into that, and the NHS values as well. Just to say as well, if you're applying for a job or an apprenticeship, on every advert on NHS Jobs, you'll see a named contact. You can get in touch with them for an informal conversation before applying and find out more about the job. You might even be able to go and visit as well and see what it's like. So that's worth knowing too. Brilliant. People in the NHS looking to change careers. Yeah, I mean, the NHS does attract career changes, both from outside, but also it sounds like you're asking around if you're already working in the NHS and want to change. If you work in an NHS trust, you should have a training or education department. It might be worth having a chat to them about the opportunities that are available. But again, get on the Health Careers website, see what there is, and then look into how you could potentially make that transition. So good luck with that, and I hope you find something to take your career to its next phase. Okay, opportunities for doctors from overseas who've already passed. So if you've done your medical qualification overseas, what you will need to do to work as a doctor in the UK is to get registered with the General Medical Council. The GMC are the professional regulator for doctors in the UK. So have a look on the GMC's website. Also on the Health Careers website, under Working in Health, you'll see there's a section for overseas health professionals there, and we've got a page of information specifically for doctors who've trained overseas. There's a process you'll need to go through to get registered with the GMC, and then you apply for a job as anyone else would through the NHS Jobs website. So good luck with that process. Okay, are there any other questions? Or are we done? looks like that might be it. So thank you all so much for joining me. I hope it's been a useful start to the day in terms of kind of giving you that overview of health careers and getting you thinking about what you might want to do. Oh, we've got another question. So from Mohammed, thank you. Do cardiologists have lots of patient contact or minimal? So cardiologists are specialist doctors, so doctors who specialize in cardiology. Yeah, they would have a lot of patient contact. Yeah. And have a look on our website. You'll see under the doctor section, there'll be a page of information for cardiologists, so you can have a look there. Okay, well, thank you all so much if that's it. But if there are any last minute questions, do pop them in. But otherwise, looks like there might be another question there from Yulia. So if you've passed PLAB, you've got the GMC license. Okay, so yes, NHS jobs is where you would need to look. So just keep looking, but also if there's an NHS trust you're particularly interested in working in, Yulia, then you could perhaps contact their department and find out, tell them what your position is, find out if they've got anything coming up, and see if they've got opportunities coming up in the future. But that's great to hear that you've got your GMC registration. Congratulations on that. And I really hope that a great opportunity turns up for you very soon. Okay, right. I think that may be it. So thank you so much for joining me, everyone. And I really hope you enjoy the rest of the day and learn lots, get really inspired, and give you loads of food for thought for over the weekend. Thanks, everyone. Bye-bye.
Share your thoughts with us on our platform, chats, or if you use social media, use the hashtag HealthCareersLive. What are you doing about self-care? Check out our free resources on health and well-being on our Health Careers Live website.
Good morning, everyone, and welcome to the National Health Careers Conference 2023.
Hi, my name is Nat.
Hi everyone, I'm Amy Robson. I'm the Deputy Director of Personalised Care at NHS England. I'm a physiotherapist by clinical profession and working in this strategy and non-clinical role in NHS England nationally.
Hi there, I'm Dr. Freddie. It's great to see so many of you here at the Health Careers Live Conference 2023.
It's always a delight to meet with you, and I hope today's session will be useful.
Maybe you're attending today thinking, okay, I know I want to do this job in the NHS. It might be that your eyes are open today to some other options as well that look really exciting to you. Or you might have joined thinking, I want to work in health, but I've no idea what I want to do. So, for you, this day is perfect.
Why is diversity in healthcare important? And I just want to touch on three main things that I think are really important when we think of diversity in healthcare.
We know that GPs look different to people now. People perceive GPs slightly differently. You mentioned earlier about how the pandemic has had a huge impact on how we operate. We see that our patients are becoming more and more complex in the way that they present.
We set ourselves a target to eliminate disproportionate referral and eliminate differential attainment in education.
To me, personalised care is both the middle of that continuum, as well as the ability to meet the person where they are in that moment of time.
It's always great to be able to kind of open people's eyes to the range of roles in the NHS and the range of routes in, because there is so much more than you might be aware of.
It really is inspiring to know that there are so many options to progress and to really put your passions across in healthcare. We're glad to announce that next year's conference, the National Health Careers Conference 2024, will take place on Friday the 5th of July next year. So please do keep an eye out over the next few months on our social media pages. Thank you very much for attending.
The NHS would be very different without you.
Join an amazing team of registered nurses working within healthcare.
Technology are going to be a key enabler to moving healthcare systems forward.
One of the things that is happening, and this is particularly important to say at this Health Careers Live, is that what medical schools are being increasingly expected to do is make sure that they're getting the right representation of society from their medical applicants. And that's quite a challenge. I don't want to go into detail, but what I'm saying is that we're trying to make it more equitable in terms of applications and who gets in terms of a cross-section of our society.
Good morning, everyone. It is so good to be back with you at Health Careers Live. So, for those that don't know me, I am Tista Chakravarty-Gannon, and I'm going to speak with you today about a paradigm shift to anti-discrimination now. Let me just check that. Yes, wonderful. My slides are up. Perfect timing. Okay. So, this is the topic for the day, this morning, and as part of that, I'm going to look at a few different elements. Just briefly, I'm going to look at regulatory reform, and I think that is particularly relevant to any health career as it affects all of you, because all professional regulators are part of this reform journey. And then I'm going to really delve into good medical practice, our core standards. But again, I think that is relevant for all healthcare professionals, given the conversations we've been having with partner organisations. So that is the plan. But before I get to that, just by way of brief introduction for those that don't know me. So I've been in and around healthcare for about 25 years now. I started off by working with survivors of abuse in the SARCs, the Sexual Assault Referral Centres. And I've had some great conversations with colleagues at this conference about my own journey in healthcare. And it was that work all those years ago that got me interested in how, when systems don't support professionals, when professional bodies, when regulators don't support professionals, then our clients, as we call them in SARC, or patients more broadly, fall through the gaps. And of course, it affects our well-being too. So when I was asked to speak today, looking at the well-being and leadership themes of today's conference, I really wanted to speak to that and let you know what is coming on the horizon and some of the work that we're doing around that piece. And I think anti-discrimination is fundamental in terms of where we need to be for leadership and in terms of improving well-being, clearly. So that's my background. And because I got interested in that systems work, I got involved in various projects. Yes, I still valued working with the client in front of me. There's nothing quite like that feeling when you've helped someone. But I wanted to look at the broader system and did various bits and pieces, for example, with Gold Standards Framework on end-of-life care. And then a number of years ago, the GMC, General Medical Council, were looking to set up a support service for doctors on the ground, and that is GMC Outreach. And this is who we are, this support service, as I say, on the ground. And I'll just let you digest those bullets there. So, as it says there, we are based all around the country. So wherever you work in your regions and nations, there are outreach advisors. And I'll come to the first bullet in a few moments. But what we do on a very practical level is we have a relationship with every single employer. We meet with them regularly, providing advice on things like, yes, complaints and fitness to practice thresholds, but also that consultancy. So, for example, if a particular organisation is having challenges with culture in a department, we then look at what support and interventions might be available to improve things. And that brings me to that third bullet. So the team are out on the ground doing that, teaching and delivering those supportive interventions. And of course, as part of that, we hear what's happening on the ground, the fourth bullet. And that can help us improve things locally. So if a group of doctors are saying to us, well, this is great in terms of the standards, but we can't really deliver that here because of workload pressures, then that's a conversation that we can have locally, but also more broadly to inform policy when there are real worries about something. So that's what outreach do. And I guess that overall philosophy is that first bullet point, upstream regulation. In a nutshell, there's a load of regulatory theory behind this, but in a nutshell, the idea is to prevent harm. If you, as a regulator, whether we are talking utilities, whether we're talking teaching, whether we're talking doctors or nurses, if all you are doing is fining organisations or striking people off, then you failed, because by that time, colleagues and possibly patients, thinking about medicine, have been harmed. So what we would much rather do is expend energy in providing that support early. And that brings me to the first point in sort of the content for today, and that is around regulatory reform. So you might be thinking, well, what about regulators? Don't they need root and branch reform in that journey to compassionate regulation? And speaking from the GMC's perspective, we have been asking for that root and branch reform for a long time now. It does require government to push through legislation. That is finally happening. But as it stands, the model is based on the Medical Act from 1983, and it is very much out of date. It creates for a far too adversarial process, and doesn't give us a choice over what we investigate. So that need for reform has been present for a long time, and it's something we've been lobbying for a long time. Now, that is not me saying that it's all someone else's fault. There are plenty of things that we can do outside of that, and we have been doing, and I think that's really, really important for compassionate regulation. But to just give you a little bit of an overview of the history, that wider regulatory reform piece, we thought it would finally happen in 2013. So now over 10 years ago, there was a Law Commission's bill and everything. And it encompassed a number of areas. So as you can see on the slide, the fitness to practice processes, which is where the bulk of the change is needed. But also things like specialist application processes. So, for example, many international graduates, the pathways open to them to get on the specialist register, they really need modernising, as well as things like education quality assurance. So those plans to reform regulation were well underway before the GMC were asked to regulate physician associates and anaesthesia associates, and now that is part of the reform picture as well. This is now finally happening. It will still be a few years before we see the full benefits of that. There are still things that need to go through, but it is happening, and that's the biggest game changer for compassionate regulation in particularly the fitness to practice sense. However, as I said, there are many things that we've been doing outside of that, that we're able to, if you will, under statute. And that's what I want to take you through. And apologies that the animations aren't working, so there's a lot of information straight on the slide here, but I'll take you through it. So I talked about upstream and downstream before. Clearly, the work that we do as regulators, there is always going to need to be some of that downstream activity. But this is a quote here at the bottom of the slide from our former chief exec who started that journey. And we started putting a lot more investment in the activities further upstream. And the apotheosis, if you will, of upstream is, to my mind, the new good medical practice. And those are the core ethical standards. So that brings me to the bulk of this morning's talk, and that is that paradigm shift to anti-discrimination. And what I mean by anti-discrimination is that for too long, I think as a society, as well as the system of healthcare in particular, we've been in a place where we've said discrimination is bad, don't do it, you know. But where we actually really need to be is in a place where we are actively seeking to prevent, actively seeking out, and actively tackling discrimination. So that is what that shift to anti-discrimination should be, rather than merely don't discriminate. And looking at the evidence base that requires this. Some of you may be familiar with the NHS RES data. So that's a workforce race equality standard. So just focusing in on ethnicity for a moment. And I'll just let you absorb the content on that slide for a moment. And that disparity is egregious, isn't it? And as I've said, it's quite interesting because RES has been around for a long time now. However, there is low awareness that the Workforce Race Equality Standard even exists. And there is, recently there's been a little bit of a lack of clarity with the MRES, that's a Medical Workforce Race Equality Standard, which started, the work for that started back in 2019 because a very different experience for doctors compared to wider healthcare professionals. And then finally, a bit of a question for you, and I am, as we go through, I am going to be looking at the chat because I do want to keep it interactive and informal and relaxed as we go. So my question for you, and I will keep checking the chat for any answers, is which group do you think, which specific minoritized ethnic groups do you think report the highest disparities in the NHS? So I'll pause and give you a few moments to answer. Anyone want to take a guess? I don't think that answer will necessarily surprise anyone. It's quite interesting. I'm contributing to 2 chapters in a book, a medical textbook for Elsevier on anti-racism in medicine, and I've been doing a load of research in this space, and some of the information has not been surprising, some of it has. But I can see no one's answered just yet, so I will put you out of your misery. And unfortunately, as I say, don't think you'll be surprised, but our Black women colleagues in the NHS and Gypsy, Roma, Traveller community colleagues in the NHS are subject to or report the highest disparities in terms of that racial discrimination. So that's a picture around racism. Just moving to some data from the GMC. And again, I'll let you absorb this. As you can see, we have seen a significant growth in international graduates. Like the data on that first headline there refers to the period from 2017 to 2021, and we're still seeing significant levels of growth in international colleagues, which, as many of you will know, it is international colleagues that frankly keep the NHS propped up in many ways and have done for decades. Now, looking at that growth and looking at the current trajectory, if that trajectory continues, SAS colleagues and lead colleagues. So those are our specialty and specialist grade doctors and locally employed doctors. They will be the majority of the doctor register by 2030 if current trends continue. And I think that's really interesting because those are the two groups that traditionally have been least supported. So that's a huge concern. And my goodness, that support is needed. The discrimination that those groups often face is quite something. The next area looks at both racism and faith-based discrimination. And then, of course, as many of you might be aware, minoritized ethnic doctors are twice as likely to be referred to us by employers, and employers understand our thresholds, whereas patients who complain broadly in line with the register, of course, don't. So that does mean minoritized ethnic doctors are overrepresented. And IMGs, international medical graduates, 2.5 times as likely. Let's call this what it is. I do get tired of people dancing around things. This is systemic racism. So this is clearly a huge problem. So is systemic misogyny. You will be aware of the stories that we're finally hearing. Unfortunately, they have always happened since time immemorial. I remember speaking to my mother-in-law, who used to be a nurse back in the day, and the things that they were expected to tolerate. But yes, we are finally hearing more and more about the stories of what our women colleagues are subject to. So in that backdrop, it is necessary to do some heavy lifting. But I use this image, and I'm glad this image is working actually, because I do get tired of how when a group raise an issue, so it is women that have been raising the issue of sexual harassment, sexual assault, misogyny in general in healthcare, and then women doctors and broader healthcare professionals are handed the prize of fixing it. And our argument at the GMC is that the organisational responsibility and accountability needs to be there. We, of course, need to hear from all groups that contribute and are subject to these experiences. So with misogyny, we need to hear from women colleagues who need to shape the response. But the accountability should lie with organisations. And as per the theme title driver, if you will, of my talk, in terms of compassionate cultures, this is where the accountability should sit. So with that in mind, we really want to use good medical practice as that lever for change. Now, it is not a panacea. It is our core standards. That implementation is key. But we have been speaking with organisations across the country who are now using it that way. And I will give you some examples as we go. Yes, good medical practice is related to doctors. However, this conversation, as I'm sure you will appreciate, has been happening across all groups. And the data that I was sharing before around racism, around systemic misogyny, this and indeed growth, for example, around international colleagues, that is something that we are seeing at NMC, at HCPC as well. And we are collaborating on a number of areas actually as regulators to improve the picture for registrants, whether it be doctors, nurses or allied healthcare professionals. Before I delve into good medical practice and the changes, I do want to take us through a very quick, and it will be exceedingly quick, canter through the last couple of millennia. I used to run a course on the history of medical ethics, so I could talk for ages, but I won't. This slide depicts ancient, if you will, medical ethics from Eastern medicine to Western medicine, whether we are looking at the Imhotep Papyrus, the Charaka Samhita or Hippocrates. Doctors have always written and embraced standards, and good standards stand the test of time. And recently we have had a little bit of pushback is too strong a word, but some interesting discussions where some feel that, well, some of these standards are really obvious. Why do we need to know these? Why bother articulating them? Couple of things. Now, detailed, and at this conference we've gone through some very, very complex scenarios in the past for those that have joined previously. So you will be aware that there are some very, very complex medical ethical areas where the standards can really help with that decision making. But the other point, yes, there are some standards that are really obvious. And as per the quote that is translated there from Hippocrates, as you can see, that relates to confidentiality, and that is now a central, obvious, if you will, that the core of it anyway, tenet of practice. But as I say, it's become that over, well, millennia. It's become normalised. It has stood the test of time. And as I say, there is this history of professionals embracing the obvious standards because they're the ones who've created them. Fast forwarding a few centuries, this next slide is when the surgeons got involved and started creating standards. And the first bullets on the first half of the slide all seem fairly logical. So try and focus on those because my animations aren't working. And I think we'd agree with the bullets on that side. They are very much drawn from the work that Hippocrates et al. Did back in the day. I won't excuse, but I'll just about tolerate the sexism purely because this is 16th century. But that aside, the principles have remained for, well, as I say, millennia, and seem sensible. However, on the other side, those 4 bullets, that's what Paracelsus went on to say, and they are not sensible things through a modern lens. And that brings me right back up to date, because good standards, good medical ethical standards, change with the social contract. And good medical practice, the revised 2024 version, a huge amount of work went into the consultation, the pre-consultation work. And what this slide depicts, this just depicts the individuals who responded to the consultation. But I'm also incredibly grateful to all of those involved in the pre-consultation work. So all of those stakeholder organisations, from the BMA, partner regulators such as the NMC, membership organisations such as Medical Women's Federation, the British Association of Physicians of Indian Origin, the Sudanese Doctors UK associations, Nigerian doctors, all these different groups helped shape the draft, then helped contribute to the consultation itself, and helped shape what we have today. And as you can see, the diversity of individual responses on the slide, that gives us real confidence that this is the sort of shared, credible contract, the current social contract, and what is needed in ethical standards now. And a big part of the change that colleagues wanted was around that discrimination piece. So I'm just going to take one of the paragraphs as an example. There are anti-bias themes peppered throughout those new standards. We've talked briefly about racism, for example, faith-based discrimination, but just honing in on misogyny, I wanted to just share this paragraph with you. We'll delve into the other areas for those joining the workshop later on. I'll pause, I'll shut up and let you just read this. And whilst you're reading that, I'm going to look at your chat. And I see one of my questions earlier, one of our colleagues did answer that. And yes, it is. It's really, really sad. But we can change it. I don't think I'm just naive. I'll come to that. Okay, so as you can see from this paragraph, this new duty in our core standards, it's really explicit. It is really explicit, and what given my background as well, the work with survivors of abuse, I was really delighted to lead on the good medical practice work for our outreach teams at the GMC, and I was heavily involved in the shaping, the consultation, and also now the implementation, which is the stage we're at as the standards just launched, or came into effect rather, January this year. And the language here, I was particularly pleased that we landed on this language, and I'm grateful to colleagues from Surviving in Scrubs, the Working Party of Sexual Misconduct in Surgery, to help us with this, because my emphasis there, effect or purpose. I think that's really important because it centres the target, the victim, the survivor. Whereas before, the argument would often be from someone who received this allegation, the perpetrator, the argument would often be, oh, I didn't mean it. Those 72 times I got too close to her and got in her space and followed her, I didn't mean anything by it. She's being too sensitive. That is now much less important than the impact it has on the individual subject to those behaviours. And that offers a real lever for organisations. I said I'd give you some examples before. So the nature of the conversations we've been having with NHS trusts on the ground, responsible officers have been saying to us, this is incredibly helpful. Whereas before, unless something got to that HR barn door obvious stage, I didn't feel I had anything to hang a conversation on. Now I do. I have a black and white duty where I can say, okay, you may not have intended anything, but this is the effect that your actions had. Let's talk about that. Let's explore that. So that is where that anti-discrimination comes in, being able to shift the dial earlier rather than waiting for something really egregious to happen. And some of the work that we're doing to support that, as I say, for those joining the workshop later, we'll go through some of this in more detail. But some of the work that I've been doing is creating videos to really help embed this work. So this is a screen grab from one of the videos, which again, I work with Becky and Chelsea from Surviving in Scrubs on. And it depicts a colleague who is subject to sexual harassment from an older male senior colleague. And we work through, in our workshops with leaders, we really challenge them. And we make it clear that these workshops are not forbidden behaviours training. And what I mean by that, there's a little bit of history to that. So many of you may not be aware, but that there was a terrible case in the 90s, actually, during a Supreme Court hearing in America, where a lady called Anita Hill was subject to horrendous sexual harassment by Judge Clarence Thomas. And that incident, that case, that brought professional setting sexual misconduct into the public consciousness, if you will. And corporate America then started to release what was known as forbidden behaviours training. And it was very much, it was alienating. It was, you must not do this. And it ended up alienating a lot of men who actually need to be the allies in this space. It was very much all men are evil type training, rather than anything which, you know, most people hearing about this are horrified and want to make a difference. And that's where we need to be. We need to have proper allyship, and we need to be in that space where, when we're doing training in that room, everyone is there to stop this scourge. And that's what we focus on. So we really constructively challenge leaders to be aware of what's happening in their workplace, but also exploring what would happen, what should happen, what protective factors can they introduce to prevent these issues, and what protective factors can they introduce when they become aware of issues. So that's some of the work that we're doing, and I'll share some more interventions with you later. But ones that are particularly effective, and sorry, because of the animation problem, you can't quite see the language there, so I'll talk you through it. But paragraphs 58 and 59 in Good Medical Practice also look at that bystander duty, if you will. So in paragraph 58, which is all, we talk about how everyone should act, and what that could be. That could be checking in on the target of a microaggression or more egregious behaviour. It could be speaking up for them, calling in, calling out. It could be a range of things, but it's a should in recognition that there will be power differentials. Paragraph 59, on the other hand, is for those in leadership roles, and it is a must. They must act. And we need to get to that place where we have active bystanders who have that confidence to act when we see those early warning signs, as well as the absolute obvious extremes. So as I get to the sort of denouement of this morning's session, I just want to explore, bearing in mind that we're talking about compassionate cultures and inculcating those in organisations, I want to look at organisational responsibilities in that professionalism continuum. So of course, at the top, we all, as individuals, have responsibilities, and the upstream end is where we are all respectful and civil, and of course, the extreme end is where that bullying and harassment starts. And the employer responsibility I will come to in a moment, because that really is key. But let's talk about GMC and indeed NMC, HCP, etc. Our responsibility as regulators is to set the standards. And yes, as I said earlier, we're always going to have those fitness to practice responsibilities. But as I say, by the time something gets to that end, the FTP, fitness to practice end, or looking at employers now bringing them in, the HR process end, colleagues have been harmed, possibly patients too. Okay. So that means we have to do the work here with that standards and guidance. And yes, the GMC, the NMC, HCPC, GDC, we can all produce these standards, but we don't have the regulatory remit to implement those standards at employer level. That's where the employer organisational culture responsibility sits. Okay. Now we have got a responsibility, albeit not a direct regulatory remit thing, if you will, but we have got a responsibility to support with that. Hence why the videos that I talked about, the workshops, etc., are all being created. And I want to zoom in on this a little bit more to make it a bit more tangible, to look at the different interventions that can take place at the different ends of the scale. So, zooming in, okay, and again, everything's come up at once on the slide, so I'll just talk you through it. As I say, At that extreme end where everything has absolutely gone wrong, so MPTS, so that's the Medical Practitioners Tribunal Service, at that end, yes, there are interventions around anti-bias that we can undertake and do undertake. So, for example, anti-bias training for panellists. Areas where we need to improve as a regulator, but also when something's at the referral stage, if someone has been subject to racism, to sexual assault, then witness support that we offer is really, really important. It really, really helps them. However, as I say, colleagues have been harmed. So therefore, it is the golden circle interventions, and to a degree the next couple as well, but the golden circle in particular, where we can make most difference, where we really need to work in order to create those compassionate cultures and that paradigm shift to anti-discrimination. So the interventions there, and there is an evidence base behind this, but the interventions there talk about those protective factors, implementing good medical practice. Now, protective factors mean good quality bystander training, not a one and done, but where we have regular conversations at induction, at grand rounds, Schwartz rounds, etc., so that there are clear expectations, so that someone who is subject to these awful behaviours is imbued with the confidence to know that her organisation or his organisation will take it seriously. So those interventions make the most difference. There is also something around when mistakes happen, or when someone perpetrates a microaggression. And as many of you will know, with microaggressions, there isn't necessarily an intention there to harm. It is through lack of knowledge, lack of education, etc. So when things like that happen, because we're all human, we're going to make mistakes. Then what do we do to prevent escalation? Well, we need to tackle those early warning signs, and that's where that second circle comes in, and that implementation of professional behaviours in patient safety programme, which is another one of our interventions. And they are built around coffee cup conversations. And too often we see that because a conversation is too difficult, it's not had. So, for example, so-called sexualized banter, so-called homophobic jokes, these disgusting things people feel awkward about and don't necessarily raise it. Okay, well, I'm not saying that those individuals, it depends on the gravity, of course it depends on the persistence, etc. I'm not saying those individuals need striking off by their regulators, but they do need a sitting down by their employer. And they need those coffee cup conversations. And this may sound a bit wishy-washy. However, there is a strong evidence base. So we did a lot of work with Vanderbilt Medical School. And this model, as I say, is the evidence base that it works. Now, the absolute egregious behaviours, they, of course, need to go straight to disciplinary. But those early warning signs can be resolved with that informal cup of coffee conversation, which still needs an infrastructure to record it, to ensure that patterns are, monitored. But the evidence shows that that first early warning sign, cup of coffee conversation resolves most issues. For those that doesn't, the second resolves a vast, vast majority. Then, of course, you have got those consistent, persistent behaviours, which, as I say, need more thorough interventions. We want everywhere to embed this model. And we released it in 2019, and it's not widespread yet, unfortunately. But my final sort of arguments, if you will, and these are the arguments that we make to organisations. If the moral imperative is not enough for you, then look at the productivity imperative. Of course, those subject to these behaviours are impacted. But also their performance is impacted, and therefore patient care, also witnesses. And if that isn't good enough for you, although my goodness, the moral imperative, as I said in the first place, should be, then get people angry. And these are all real examples that my team have heard on the ground. One of them was said to me, and the response I received was, oh, it was just banter. I mean, other banter is available, you know. And the coffee cup conversations for the less egregious do work. As I say, I've had experience of doing that. I've had a case where someone really thought the women enjoyed those jokes. He learned. I've had someone else who really didn't learn, and he's no longer with the organisation I was working with at the time. We can stop this, and we need to. And as I say, the new good medical practice isn't a panacea, but it does put it all in black and white and gives people that lever. And the good news is that those golden circle interventions work. So that is it from me, and I am at time, but I am going to have a look at the questions, and I'm going to just check with colleagues if we've got time for me to answer those, or if I should do that afterwards. Right, so what would I recommend that you do in your everyday practice to promote change? I think that's a really, really good question, and I will go into it in more detail in the workshop. But what I would say is make people aware of the standards, link in with your outreach teams so that we can deliver the interventions locally, encourage that calling in and calling out. Don't be that bystander. Be that active bystander. Check in with colleagues, and if you feel confident enough, then, as I say, call it out as well. Okay. Right, so that's a really good question. Who is best suited? So the actual model involves training people, and my team do that training. So trained colleagues, and they can be any level, but seniority, of course, empowers people with confidence. But a trained group to have those coffee cup conversations and linking in with HR so things can be monitored is what makes a difference. Okay, any more? Yes, we absolutely can. Yeah, please do get in touch, and we'd be more than happy to do that. Thank you, Adam. And Suad. Okay. Yes, this change is really important. And in fact, it's a good friend of mine, a Sudanese doctor. She really helped me create some support for international medical graduates. And you may hear about that later at the second workshop. Thank you. Yes, the change is needed. And I am hopeful now. We've been talking about these things for a long time, but I think we've reached that tipping point where it cannot go back in the box. I'm seeing lots of places, not enough, but lots of places making these changes and using, as I say, good medical practice and other things as a business case to say, yes, we are going to do this. Okay. Brilliant. Thank you, Abdul. Yes, I was so pleased, as I say, to be involved. These standards are very close to my heart. Yeah. Okay. Thank you very much for your time, and I will see some of you at the workshops later. Thanks. Bye.
My name is Mark Radford. I'm the Chief Nursing Officer for Health Education England.
I'm Sarah. I'm a neurosurgery trainee currently working in Cambridge.
I'm Adrian James. I'm the President of the Royal College, and I'm really delighted to be here.
My name's Abby, and I'm the Careers Information and Quality Lead for the NHS Health Careers team. I hope to be able to get across to you some of the amazing opportunities within the NHS.
We have got occupational therapist, speech and language therapist.
So we're going to talk about good medical practice, we're going to talk about protecting patient safety.
Because of restrictions, because of remote working, because of the lack of face-to-face contact, because we have to manage patients a different way, we've had to think differently about how we manage this work and how we use technology.
I'm in London, so good to see you. I think we've got Ian here as well, haven't we? Hi, Ian.
Hey guys. We are not the only people who are facing problems, but actually through sharing those problems, we can become the health professionals that are required for the globe and for the NHS in the future.
It's been really interesting hearing all your top tips. I've got my list now. I can pack my bags. I'm going to wear my seatbelt for safety, but I am going to look out the window ahead of me and enjoy the trip.
It's just about us finding the greatness within us and bringing it out and being our best self.
Many people know there are roles such as nurses and doctors. However, did you know there are 350 careers available in the NHS?
Welcome to Health Careers Live.
Thank you very much. It's great to be here in Altrincham, where the National Health Careers Conference first started 5 years ago. And since then, it's been doing a fantastic job communicating to many thousands of young people the great spectrum of different opportunities there are in the National Health Service and in the wider health sector, giving those young people the wonderful opportunity of fulfilling careers, serving the community and helping to make our country and the world a better place.
Young people from around the Northwest have taken part in an event to make jobs in healthcare more accessible to students from all backgrounds. Universities and groups, including the British Medical Association, held workshops at the conference in Trafford, which was organised by volunteers.
Well, I think it's the right idea at the right time, because Brexit, whatever we think about it, will pose challenges for the National Health Service in terms of workforce. And as a country, we will have to get better in the next 10 years at training more of our own doctors and nurses, and we'll have to make it easier for young people to find a route through after school, through university, into the NHS. So this is something that I take a great interest in, and I think we need to make it easier for people to make that progress onto the ladder and work in the NHS. You know, the scrapping of the nursing bursary, the trebling of tuition fees has made it harder for people from less well-off backgrounds to nurse or to become doctors, and we need to open up access for them. So this is a great initiative. Happy to give it my support, and I really look forward to seeing the conclusions of it. Overall, I think we need to do more of this to help young people work in our NHS.
Each of our 14 allied health professions are unique by role and diverse in skills. So given your chosen profession and you are training to be a diagnostic radiographer, if radiography was a cocktail, what would you suggest are the key ingredients that need to be mixed together based on skills, interests, strengths that would produce the best top-class diagnostic radiographer?
Good morning, everyone, and welcome to the National Health Careers Conference 2023.
Hi, my name is Nat.
Hi everyone, I'm Amy Robson. I'm the Deputy Director of Personalised Care at NHS England. I'm a physiotherapist by clinical profession and working in this strategy and non-clinical role in NHS England nationally.
Hi there, I'm Dr. Freddie. It's great to see so many of you here at the Health Careers Live Conference 2023.
It's always a delight to meet with you, and I hope today's session will be useful.
Maybe you're attending today thinking, okay, I know I want to do this job in the NHS. It might be that your eyes are open today to some other options as well that look really exciting to you. Or you might have joined thinking, I want to work in health, but I've no idea what I want to do. So, you know, for you, this day is perfect.
Why is diversity in healthcare important? And I just want to touch on three main things that I think are really important when we think of diversity in healthcare.
We know that GPs look different to people now. People perceive GPs slightly differently. You mentioned earlier about how the pandemic has had a huge impact on how we operate. We see that our patients are becoming more and more complex in the way that they present.
We set ourselves a target to eliminate disproportionate referral and eliminate differential attainment in education.
To me, personalised care is both the middle of that continuum, as well as the ability to meet the person where they are in that moment of time.
It's always great to be able to kind of open people's eyes to the range of roles in the NHS and the range of routes in, because there is so much more than you might be aware of.
It is inspiring to know that there are so many options to progress. And to really put your passions across in healthcare. We're glad to announce that next year's conference, the National Health Careers Conference 2024, will take place on Friday the 5th of July next year. So please do keep an eye out over the next few months on our social media pages. Thank you very much for attending.
Good to be doing this workshop with you. Hi, everyone. Sorry, I was on mute there, which is such a schoolgirl error, considering that I've been speaking at conferences for so many years now. But lovely to be back again. And for those of you who were at that first session that I did, this session is the sort of more in-depth focus on what I'd just started to touch on earlier. So this is the focus. Okay, I'm going to talk through some of the key changes in good medical practice, but really, really explore those anti-discrimination themes in more detail. And I'm going to be using case scenarios with you as well. There are a couple of videos, which all things being equal, the sound will hopefully work. But if there are any challenges, then they're only short clips, so we can work around that. But it is interactive in other ways because I am using Mentimeter. So just to test that, if I could ask you to grab your mobiles and log on, well, go on to menti.com, just type in menti.com and you'll get a screen that allows you to enter that code that is there at the top of the slide. And I just tested it all during the break, so all things being equal, it will work. My, yeah, it's going up for me. So I'll just give you a few moments to get on. You can do it in another browser screen if that is easier for you. There we go. We have some people logged on. Brilliant. I always put in the define read. It's yeah, I have to say there are many documents that I just have a scan of rather than a full thorough read. Okay. Right. Now, oh, we've got some more responses coming in. We haven't got any yeses yet. But that's fine. Okay, brilliant. Thank you. I am pleased to see that some people have scanned it. But what I'm going to do is just highlight the key themes for you. Okay. So there are a number of domains. I'll take you through those in a few moments, but these can all be put into these 5 key themes. And as you will see, of course, we still have duties around patient care. So promoting patient-centered care and that continuity of care and delegation, all of that. So things that you will be familiar with as healthcare professionals and aspiring healthcare professionals around what we were talking about before, confidentiality and shared decision-making are certainly there. And they haven't changed. Not a great deal anyway. As I said earlier, there are anti-bias themes peppered throughout, but the crux of those duties haven't changed. However, there are 3 themes here that you can see are all about that culture and anti-discrimination piece. And these duties are either brand new, representing that seismic shift, or they are much more robust and explicit than they previously were. So with all that in mind, my next question for you, given that those duties are so much more explicit, what do you think? So that's quite interesting. So far, everyone is going for yes. I asked this question to a group of responsible officers not too well. I've been doing a series of events for them. And it was quite interesting, given their role of accountability in the organisation. So it was quite a mix of responses. We've got one person saying no. Well, the brave individual not following the group there is correct. It doesn't change the thresholds. And that is because I like to see, the way that I like to think of it, the standards are over here. Fitness to practice is over here. So the standards describe good practice. It is what a good doctor looks like, recognizing that we are all human and will, of course, make mistakes. Yeah. So therefore, a departure from good medical practice is not synonymous with fitness to practice necessarily. It depends on so many factors, other factors. So it depends on the gravity. It depends on the context. So what were the workloads like? What had that person been through that day? Is that person going to continue to practice? Are they just about to retire, for example? It also depends on the remediation and insight. Could it be that there is an area of practice that this person really, really struggles with, but they've got great insight on that and they're remediating their practice? So it depends on all of these factors, and therefore good medical practice, try and view that as it is a document around medical ethics. It's what that good doctor, and it will apply to physician and anaesthesia associates too, once they're in regulation, that's what it's for. It is not a set of edicts from up on high. It is not a rule book by any stretch, okay? You can exercise your professional judgment around those duties because, again, that professional judgment is going to depend on everything in front of you, okay? So with that in mind, let's have a look at the 4 domains. Now, the domains, knowledge, skills and development, going anti-clockwise, which is slightly counterintuitive, but knowledge, skills and development, patience, partnership and communication, and trust and professionalism. Those 3 domains are where there's been attenuation, some slight changes, but no real revolution, if you will. So, for example, in knowledge, skills and development, in the previous set of standards, we've talked about reflection before. This time we talk about reflection, but we talk about considering your own biases as part of that reflection. So as I say, anti-bias is peppered throughout, but that's not a seismic shift. You'll recognise the duty if you were familiar with Good Medical Practice 2013, the previous version. We've also brought into Good Medical Practice from our decision-making and consent guidance, we have brought in some duties into Good Medical Practice. From our social media guidance, we've brought in some duties into Good Medical Practice. So no real change, we've just promoted it into that core set. And that means that it is only that new domain, colleagues, culture and safety, that's really changed. All that said, there is one thing that I do want to explore with you. And that's because it's led to a lot of conversation online. So I feel it would be remiss of me to not explore it with you. And that is, in the duties for a long time in the standards, we've talked about being courteous and respectful. With this new version, we've added a word. We've added the word kindness. So treating your patients with kindness as well as courtesy and respect, and colleagues too. And that resulted in a lot of debate, which I found really interesting. And there were some people that were really, really worried about it. Some people who were really strongly advocating for it. There was a time where we thought, okay, we might remove that word. But then there was, again, a lot of pushback to say, no, keep it in for these reasons, which I'll come to in a few moments. But I wanted to test your thinking. So with that in mind, does anything worry you about the inclusion of the word kindness? So saying you must treat patients and colleagues with kindness as well as courtesy and respect. So I'll give you a bit longer because you get to type in a response here. It's interesting. Yeah, so that's the main thing that we're hearing from people in terms of the worry. Yeah, that's a really, really important point, and I'll come to that, the whole gaslighting and exploitation. People misuse it, yes. So as you might imagine, I've been in the feminist space for a while now, given my work with survivors of abuse. And yeah, that whole be kind hashtag that was used against feminists well before recent debates in healthcare. Yeah, pick holes being walked over. That links in with what a number of people are saying, and I'll come to that. Yeah, subjective. That's like the first comment, isn't it? Okay, so thank you. I'll keep scanning this. Yeah, for not fitting in with this concept. And I think that's such an important point. So let's look at those points first around the subjectivity, not fitting in, etc. How do we measure it? Well, first point that I'd make, let's go back to what I just said about what the standards are. They are not fitness to practice thresholds. They are what a good doctor looks like. And yes, this is a subjective subjective word in the sense that my kind might be very different from what your version of kind is. But equally, my version of courtesy might be quite different from what your version of courtesy is. Within ourselves, any healthcare colleague wants to demonstrate what they perceive to be kind. And bearing in mind the standards are what that good doctor looks like and not fitness to practice, we think it is a reasonable word to understand. However, this brings me to the other concerns about not fitting in and it being weaponized, which is essentially what a lot of those comments are saying. And one thing that I'm seeing a great deal of is a conflation of kindness with niceness. Now, if we weren't talking about the regulator setting this as a duty, we want people to be kind to us. We want to be kind to our patients. Now, that does not mean that we want to be doormats, of course. And being nice, again, it's arguable, but nice when you don't mean it, nice when there isn't any compassion behind that, nice as in just putting up with things that you don't want to put it up with things is very different from being kind. You will have heard the aphorism that sometimes you need to be cruel to be kind. Now, I'm not saying that that's what the guidance is talking about, but that brings me to my next point. All the feedback that we received. was really helpful in helping us decide to keep it in, but helping us to change the draft so that we added a lot more detail. And that detail makes really, really clear that being kind does not mean that you're not going to break bad news. It does not mean that you're not going to raise concerns. You're still going to be doing all of those things. Yeah. So it's how you do it that matters. And yeah, one person's view of how you do it might be different from another's, but it's what you're aiming for, yeah, that matters. So hopefully that clarifies the inclusion of the word kindness. And I'm just going to, in fact, that the person who's commented most recently, almost as if you're a plant, and I promise I won't, that brings me to my next point. If we do not include kind behaviours by seniors, juniors will not role model these. Now, there's another element to that I wanted to speak about. And when we were consulting, one of the stories that we heard was from a group of trainees who were really passionate about including the word kindness. And that is because they had been subject to really unkind behaviours. Most shockingly, locked in a room, kid you not, locked in a room until they agreed to cover rota gaps. I mean, unkind doesn't even begin to cover it, you know. So this is bearing in mind that good medical practice is about driving culture change. We want kindness in the culture, but at the same time, by way of reassurance, it's not a fitness to practice threshold. It's a lever for that positive change. So thank you for all your comments, really, really helpful. But I hope that demonstrates that all of those domains, there's been attenuation that is evolution rather than revolution, to use that slightly trite phrase. And it's all about driving cultural change. But where we've got that seismic shift in driving cultural change is here in colleagues, culture and safety. And that is where we talk about being kind, as well as courteous and respectful to your colleagues. And again, that doesn't mean you're not going to raise concerns about them. So these are kind of in the teal boxes. Those are the themes within these this domain, and it's predominantly paragraphs 48 to 59, but also, for example, 63 and 64 talk about induction and support, especially for international colleagues, for example. So this whole area is very much about that significant shift. And I'm usually allergic to too much text on slides, but I do want to showcase some of those changes. So this next slide, I've excerpted elements from the intro to the domain, but also excerpted little bits of some of those duties. So as I say, 48, treating colleagues with that kindness, courtesy and respect because we deserve it. We're all human. We're not going to be perfect all the time. But as I say, the standards recognise that. But this is what we should be doing. And that brings me to Anika's story. Anika, who was not treated with kindness. So the scenario, you bump into Anika. Anika is a new colleague, internationally qualified, and she is she's just started as a nurse, and she is reprimanded. She tells you, when you ask her why she's upset, she tells you that she's been reprimanded for staying late, whereas a male colleague was praised as conscientious for doing exactly the same thing. And it got her a little upset, and you try and explore it with her, and she just says, oh, I'm probably just overthinking it. It was just now, and I was a little bit upset. You probe a little bit more. And Anika tells you that actually she'd had a difficult day all round, and earlier on in the day, bearing in mind that she's really pretty new, a couple of weeks maybe into the organisation, a senior nurse colleague said to her, why are you just standing round? And she said, oh, I was just waiting for instruction. I was always told to wait for my senior to tell me what to get involved in. And the nurse colleague gets quite cross and says, that is not how we learn things around here, and kind of huffed off. Okay. So this has clearly shaken her a bit as well. And you've always thought, albeit it's just been a few weeks, you've always thought of Anika as quite quiet and not getting involved in things. But as you start to converse more with her, albeit she's still trying to dismiss things, you realise that she's feeling left out. She's not invited to group socials. And then finally, as he's sitting down for a coffee, she reveals more to you, and she put in for leave before she started, when contracts were all signed and all of that. And she's just been told that her leave, albeit that it's 2 months away, is not going to be granted. And that's her sister's wedding in Kenya that she's now not going to be able to go to. And Anika's story, of course, I've made her up, but I've made her up based off many of the trainees, locally employed doctors, nurse colleagues that we hear from. And what she is being subject to here, unkindness, but also unwritten rules and very possibly discrimination. And there's been work on unwritten rules in the system for years, absolutely years. Okay. So from nearly 25 years ago, this work was looking at cultures in terms of governance. And clinical governance lead said this: there are microcultures, every single different practice, but then also ward rounds. Every ward round might have its own new dynamic culture, the wider hospital trusts that you might work in, the department, etc. And they all have their unwritten rules. These are around governance, but Anika doesn't know what the unwritten rules are. No one's bothered to tell her. No one's given her a good start. And she's an outsider. They've made her an outsider by not welcoming her in. Unwritten rules as well can be really, really powerful. And this next slide is from the same research here from Cullen, Nichols and Halligan. And I thought it was an apocryphal story, but it was in the research, so it's good enough for me. So I'll shut up and let you read that. I've injected it I've inserted it to inject a bit of levity, but it's interesting. And we have seen, many of us, I think, these scenarios where, the senior says that, so let's just do it, even if it is ridiculous, or the senior is modelling unkind behaviour, so we don't feel that we can be kind, or the senior is being bullying, don't feel that we can be active bystanders. So, unwritten rules affect us all, and I'm just going to skip this slide because I want to get to a couple of more scenarios, and And if you've got any thoughts on that, then of course you've got the chat available too. But what I want to get to is how we overcome these unwritten rules and the very negative impact these unwritten rules, which are essentially the culture, have. And that is that they have a disproportionate impact on some colleagues in particular. And as you might imagine, those colleagues are ethnic minoritized colleagues, internationally qualified colleagues, and women. And what this model here is from work that's been done for a long time now. This is from 2014 on differential attainment. So this is where colleagues, particularly from minoritized ethnic groups, different faith groups, etc., don't have the same positive outcomes as, let's say, a white male colleague. Okay, they would be represented in the low risk area, where they have the best outcome, whereas women, minoritized ethnic, and some faith-based groups are subject to vulnerability processes, have a poorer outcome. And what we need to do is put in those protective processes to ensure they have a better outcome. Now, earlier this morning, I talked about protective factors when I shared that screenshot of the sexual harassment video. And this is what we want people to do, as I said, put in those protective factors, which was also on that circle slide. We know the evidence base shows, just as I said, our IMGs, international colleagues, minoritized ethnic and women, are subject to risks and vulnerabilities. And these are what some of those are. As I say, there's really strong academically robust evidence around this. And there are all kinds of things like cultural communication. So I'm doing some work. One of the portfolios I lead at the GMC is for international colleagues. And I'm doing some work on cross-cultural communication. I'm also going to Japan very soon. And as part of that work, I was looking at, just out of interest, Japanese culture. And I was comparing that to Dutch culture. And professionally speaking, if something goes wrong, let's say in Japan at work, then it is normal to provide a lot of context, a lot of explanation. It's also normal in Indian culture, in Nigerian culture. In Dutch culture, it's not normal to give all of that context. It's much more normal to be direct and give you the headlines. So let's say a doctor who trained in the Netherlands is speaking to a doctor who trained in Nigeria and asking them what went wrong. And the Nigerian doctor is giving them all this context. The Dutch senior doctor might be sat there thinking, they're making excuses. They're giving me far too much information. Why aren't they being straightforward? Similarly, if it was the other way around, the Nigerian doctor might be thinking, they're not giving me any detail here. What's missing? So this is why we need to, it's just a small example, but hugely impactful example of why we need to overcome these vulnerability processes. I shared before the systemic racism that we have in the system. I shared before, only this slide has some more data, the systemic misogyny. I shared before that we need to work together to make this stop. So with all that in mind, I'm going to, earlier I shared paragraph 57 with you. I'm also going to show on the next slide, paragraph 56 and 57. And again, I'll let you scan and digest these. And both, I talked before about paragraph 57, so I won't labour that. But as you can see, both of these go beyond the UK law. And they go beyond the UK law because, let's face it, it's not like someone who sexually assaults a colleague, or it's not like someone who is overtly racist to a colleague didn't get the memo that these things are bad. Those terrible behaviours need to be tackled. However, as I was saying before, it's the early warning signs that this language allows us to tackle because it goes beyond the law. Okay. And again, I won't labour this too much. I wasn't sure if we'd have different joiners for this section, but this is why the different interventions matter at those different times, but in particular, the golden circle ones. And I've talked a little bit in this workshop about that start for our international colleagues. So I've added some more into the golden circle there. Yeah. And that all makes a difference. And of course, and because I'm using Mentimeter, you can see the full content here now, the bystander duty. So I want you to have all that in mind as we now watch a video, which I am really hoping the sound works. I should have tested that earlier, but let me just play that, and I'm sure the team will type into the comments if it's not working.
Davis is in bed 7. See you later, Dr.
Dr. Ban?
Yeah, they can't say my name.
What, Banerjee?
I know. Hello, Mr. Davies. My name is Dr. Banerjee. I understand that you have some pain in your tummy, so I would like to examine you and try and see what's going on.
Sorry, who did you say you were? Doctor what now?
Dr. Banerjee, I'm one of the emergency doctors.
Are you sure you're not one of the cleaners or a nurse?
No, I can assure you I am a doctor. It says here on my lanyard.
Well, you could have picked that up from anywhere. If you are really a doctor, where do you come from?
Come from Newcastle.
No, but where are you really from?
Mr. Davies, I can assure you that I'm both a doctor and that I grew up in Newcastle. Now, I am really concerned about this pain in your stomach. We need to find out what's wrong with you.
Well, I'm not sure. Is it possible for me to see another doctor?
Well, we are extremely busy at the moment, and like I said, I'm really concerned about the pain you're in. But if you'd like to tell me the reasons why you'd like to see another doctor, then that would be really helpful, and I can see what I can do.
Right, now I'm going to show you her piece to camera.
This is not the first time something like this has happened to me. It's really difficult to manage because I know I have to be respectful to patients and make sure that their care is my priority. But this kind of thing, it's hard. I know that Mr. Davies is only questioning whether I'm a doctor because of the colour of my skin, and it's really offensive when people don't believe me when I say that I come from the UK. The NHS and Trust have zero tolerance policies on racism, but it happens all the time. That's why I asked Mr. Davies to explain why he wanted to see another doctor, but sometimes I just want to challenge patients head on when they behave like this, but I'm not sure that I should. It really affects me. It's why I brush off the little things like people not being able to say my name. At least they're friendly. It still gets to me, to be honest, but it's nothing like the really horrible stuff I get. In my old hospital, one of the nurses said, I always smell of curry. I mean, I don't even eat curry. And of course, patients like Mr. Davies. Anyway, another tough day and it's only 10 o'clock.
Can't tell you how cathartic it was writing the video, and the actors were so good. I was there on the day of filming to help, check for details, etc. Even though I wrote the thing, she was brilliant. It was so moving. And I've put up a vote, but as you have a look at that, one of the things that we really want to achieve with this, as you could see Dr. Banerjee there, she has no confidence that she can raise these things. She has no confidence that these things will be taken seriously. She talks about the so-called zero tolerance policy, but then what's actually happening? We need the Dr. Banerjees of this world to have confidence this will be tackled. You can't stop patients from being racist, but you can take action. And again, using these videos and other work, to be fair, that's been going on in the system for a little while now. There have been places that have not just introduced their zero tolerance policies, but they've actually introduced actions that follow, such as yellow card and red card systems against patients, ending relationships, ensuring that senior colleagues immediately have their back to someone who faces that awful behaviour. So, next question for you. And I have to say, I find it really, really interesting with some groups when I share this or when my team shares this, they pick up on the awful overt racism. They don't always pick up on the fact that we have a colleague here who can't be bothered to get her name right because it's such a difficult name. So that brings me to my next question. What do you think? I was with 107 trainee colleagues the other night, and just under half said that the overt racism would be taken seriously in their particular placements. Only 4 thought that the microaggression would be taken seriously. Both are terrible results, but wow. Yeah, I'm glad someone has said yes. And this is it. These things, as Dr. Banerjee reflected in her piece to camera, can often be dismissed as little things. They're too hard to deal with in people's minds. It's not like a colleague is trying to be evil. It's not like he needs striking off. But as I said earlier in this morning's sessions, someone needs to have that accountability to sit down with him and say, hang on a minute, it's not really appropriate, is it? How would you like it if someone said that they can't possibly say your name, doesn't have the respect for you to say that? And on a personal note, you can tell that I'm speaking, I imagine, from quite a personal angle here. On a personal note, when clients, as we call them in SARC in my other job, when there is discrimination from them, obviously I'm not saying I'm okay with it, I'm not. But if it's a colleague, I feel that a lot more, it has to be said. So when we run this with organisations, as I said in this morning, we challenge them to look at their processes and the actual actions. Yeah, a policy, That's fine over here. Just like good medical practice, it gives you a lever. It's policy, if you will. It has to actually have actions to back it up. So what I'm going to do now, I'm going to show you another very short pair of clips. This time, Dr. Lee, who you saw screenshots of earlier around sexual harassment. Now, I'm going to give you a little bit of content warning. It's sexual harassment. There is no physical assault here, but nonetheless, it does bring up things for people. And I would urge you not to share things here, not because I don't care, but because I often find that when we're talking about these issues, people want to share. You feel empowered. I certainly do. And then we can sometimes regret these things. But I will signpost to support if you want to talk, because, of course, I'm more than happy to do that. But without further ado, just so that you have sight of the kind of work we're doing around misogyny.
So let's go through the jobs list.
Is Anna around? I need to speak to her about something. Ah, there she is. Our hottest new addition to general surgery.
Sorry?
Well, that dress is far more sexy than scrubs. I'd pay more attention if you'd look like that in our next audit meeting.
I need to go.
For heaven's sake. Can't you take a compliment?
And her piece to camera. It's quite interesting. The number of people in a room who said, oh, that kind of thing doesn't happen. Happens all the time. People wouldn't use language like that. Yes, they do.
He keeps doing this, and no one ever says anything. I don't know what to do. He's my consultant. At first, I tried to be nice, asking about his wife and kids. And my educational supervisor said he's a good guy, really. But, well, the other day I was alone with him, and I felt uncomfortable with him getting too close. I don't know if it's just me, but it just didn't feel right.
I'm free after work tonight, and my wife's out of town. I would like to go for a drink, and we can check over your audit.
I'm busy tonight. I need to go. It happens all the time. I don't know what to do.
Many of us will have experienced things like that. Many of us, possibly several times. And the number of times let's say that something does escalate, and you hear, yeah, he was always a bit like that. These things are hidden secrets. And I saw in the chat earlier, the team was saying eyes and ears. These things need to be raised, but you can see Dr. Lee, she's tried to raise it. And she's been told he's a good doctor, really. I've been speaking with someone recently, and they've been subject to awful behaviours from a very senior colleague. And everyone else thinks he's a great guy because they have not experienced these behaviours from him, and they can't envisage that. So, I mean, it's being dealt with now, but to just reassure you. But yes, we need to act. And I've shared the work that we're doing in this space. But one thing that I've found really, really uplifting, one area On the back of good medical practice and the new sexual safety charter, One Area invited me to speak to an event that they organised, and I was really pleased to be there. And they have worked with us to develop a toolkit, so those practical actions, and it's a whole area. And they are looking at different interventions so people are comfortable to raise these things, so those early conversations do happen. Now, of course, that is what they need to do as leaders. In the meantime, until it all gets to a perfect world, which, let's face it, it's not going to happen, but I do think it's getting better because, like I said earlier, it's not going back in the box. You also need to know your roots if you don't feel comfortable in your organisation. So this, and of course the slides will be available for you later as well, gives you an overview of the routes available. Someone I spoke with recently told me that her view of the GMC changed considerably because she used our confidential helpline. Didn't feel like she could go to her organisation and found it so very incredibly helpful. So there are routes for you, whether it is freedom to speak up in your own organisation or confidential helplines or allies. So as I wrap up, we are encouraging those leaders to use good medical practice as a lever. We have seen organisations use good medical practice as a business case to bring in that bystander work, that proper bystander work, have ongoing conversations, etc. HR teams are launching things like inclusive HR. Cheryl Samuels, some of you may have seen, does great work in this space. So there's lots of good news. I've shown you some shocking things. We've talked about difficult things. But I think these things have to be talked about because we spent too long not doing so. And that's why we have the problems we do. Good news is that these interventions work and some places are implementing them. There are challenges. We have, as I say, no regulatory remit, for example, over HR. For example, around making organisations embed differential attainment interventions. But we are working with them to influence them. And that, as I say, is having an impact. There is a lot of misinformation out there, and that's why I again encourage you to raise awareness of the work in this space, use your networks, and as someone said earlier, we will really be delighted to come and support you in your organisations. And that brings me really to the penultimate slide, the final one's just a thank you. Please use us in outreach. We're having these conversations everywhere. But if your organisation would benefit from this, then please do invite us. Thank you very much. I've been keeping an eye on the comments and there haven't been any recent questions, but I'm around. So if anything does strike you, then I'll be around to answer it. Thank you very much for your time. And I hope that was helpful.
Thank you very much for watching this morning's sessions, and particularly to both Abigail Changer and Tista Chakravarty-Gannon for their fantastic talks. So what's to come next? Well, we're going to have a lunch break for about 20 minutes or so, and then we'll have Luke Austin speaking about how new healthcare professionals can work safely at night. And then Tista Chakravarty-Gannon will be back with a session aimed at IMGs titled Welcome to UK Practice. Then we'll have another short break, followed by the remaining sessions, which I'll talk about later. In the meantime, please keep talking online using the hashtag HealthCareersLive. Thank you.
Hello, my name is Luke Austin. I'm currently a doctor working in anaesthetics and intensive care, and it's a great pleasure to speak to you today at the Health Careers Live National Health Careers Conference on this question of night mode. How can new healthcare professionals work safely at night? Which is based on a chapter from my book, The Bleep Test, How New Doctors Can Get Things Right. We'll start with a quote. "No man knows till he has suffered from the night, how sweet and dear to his heart and eye the morning can be," which is from Dracula by Bram Stoker. And I think it's something that will resonate with many of us who have done night shift in the NHS. Why is working at night so different and so difficult in hospital? Well, the hospital is a different place at night. Your footsteps ring out against empty corridors, which only a few hours ago were bustling with elderly people being pushed in wheelchairs, families visiting their relatives' wards, hospital charity volunteers recruiting for the fun run, and patients being transported to CT scans with their entourage of beeping monitors, equipment, nurses and doctors. Now the commotion and hullabaloo of the daytime is gone. The humdrum and routine comings and goings of hospital life are finished for another day, and left behind are only the skeleton crew of staff deemed necessary to cope with the emergent and the urgent, the patients and the medicine that cannot wait until the sun rises and the hospital machine boots up once again. It is certainly true that whether you're a pharmacist on call, a chest physio coming into the respiratory ward, a nurse or a doctor, the work you're required to do over the night shift is fundamentally different and likely more challenging compared to that in the daytime. There are no routine prescriptions or routine referral letters to be processed. There's only the urgent tasks to look after the really sick patients who need us. Are hospital patients less safe at night? In 2010, Maggs and Mallet retrospectively analysed a year's worth of emergency admissions to a medium-sized district general hospital, finding that mortality was significantly higher for patients admitted out of hours compared with in hours, and for those admitted at night compared with during the daytime. Crucially, though, they only adjusted their data for age and sex, not for admission diagnosis or underlying comorbidities, acknowledging therefore that it was not clear to what extent the mortality differences were due to the patients admitted out of hours or overnight just being sicker to start off with. However, they did comment that the fact that the differences were still seen in late mortality, which were deaths occurring at more than 7 days since admission, as well as in overall mortality, suggested a strong role for patient factors at admission, since any variations in the healthcare quality provided arising around the time of admission would seem to have a much smaller effect on those deaths that occurred more than 7 days down the line. What about the effect of the night shift and working night on our own individual performance of those crucial tasks we need to do? In a 2018 report titled Fatigue and Sleep Deprivation, the Impact of Different Working Patterns on Doctors, the British Medical Association highlighted the negative cognitive and psychomotor effects of fatigue and sleep deprivation on task performance, working memory capacity, and attention. Whilst their review did comment that the available evidence was limited, they pointed to multiple observational studies that linked self-reported fatigue-related medical errors to patient injury or mortality. They also highlighted a prospective randomized study that compared rates of serious medical errors made by critical care interns in the United States working shifts longer than 24 hours versus shifts of less than 16 hours. Unsurprisingly, interns on the rota that included these traditional extended duration shifts, which were more than 24 hours long, committed 36% more serious medical errors, 21% more medication errors, and 5.6 times as many diagnostic errors. Although these findings from the US are likely not completely generalizable worldwide, since their residency shifts are often dramatically longer than those in comparable healthcare systems, the key message is clear that accumulating fatigue is likely to decrease the safety of those patients in our care. So what else do we know about the effect of number of hours on shift or number of shifts completed on our chances of making mistakes? In a non-systematic review article titled Shift Work, Safety and Productivity, published in 2003 in the journal Occupational Medicine, Folkard and Tucker combined data from 3 studies in different industries into shift duration and accident risk, and found that the risk of accidents after 12 hours worked was approximately double that seen at 8 hours worked. So if you look on the left-hand side of the screen here, you can see on this chart that for the first 8 hours of shift, the relative risk, or mean relative risk, remained relatively constant, but increases dramatically in hours 8 to 12 of the shift. They also showed that there was an increase in risk across successive night shifts. Just look at that increased risk by the 4th night shift compared to the 1st, which I think supports the anecdotal feeling amongst most doctors that by the end of the 4th night shift, you're really approaching your limits for retaining an acceptable level of performance. This last graph on the right is also quite interesting, showing that the minutes since the last time a break was taken also contributes to the relative risk of accident. So, how can we best cope with this situation? What can we do to try and optimize ourselves, given what we know about our own physiology, to try and provide the best care for our patients? Well, strategies and techniques for coping with night shifts are common topics of conversation in hospital staff rooms, and lots of theories are around, but some are more accurate than others. One common misconception is that we can flip our body clocks when we do a set of nights. The first night shift is a bit rough, people will say confidently, but once I've synced into night mode, I'll be totally fine. It would be nice if this was true, but unfortunately it is a myth. We cannot flip our sleep-wake cycles. In the book Why We Sleep, Professor Matthew Walker explains that when he flies east from San Francisco to London, the sunlight signals to the brain's suprachiasmatic nucleus mean that he will eventually overcome the jet lag, but unfortunately the process is slow. It's much too slow. For every hour you're in a different time zone, he writes. So if every day you're in a different time zone, he writes, your suprachiasmatic nucleus can only adjust by about 1 hour. So for a doctor who is staying awake longer than their usual circadian rhythm is expecting as they come onto night shifts, which is our equivalent of rapidly flying east through multiple time zones, there is no hope of circadian resynchronization coming to our rescue. We would have finished our run of 4 night shifts before the process is even halfway done. However, the body clock flipping believers are right about one thing though. The first night shift usually does feel the roughest. This common observation actually has to do with a concept called sleep pressure, which is the second determinant of wakefulness, which, together with the internal circadian rhythm, governs whether or not we feel alert, fired up, and ready to go. In sleep physiology, these 2 key factors are referred to as process C for circadian wake drive and process S for sleep pressure, which is mediated by accumulating levels of adenosine in the brain. Over the course of a normal 24-hour period, process C and process S work in tandem to keep us awake when we should be awake and to help us sleep when we should sleep. So in the morning, process C is ramping up and cortisol levels are increasing, combining with the low levels of sleep pressure at this early stage of the day to mean that we are appropriately wakeful. So when the distance between process S and process C is small, there is a strong urge to stay awake. Then, as the day wears on and process C turns the corner, decreasing the circadian wake drive, and sleep pressure continues to build as our hours awake accumulate, the distance between the two grows until eventually we fall asleep. Sleep washes out the accumulated adenosine, reducing process S back down until sometime after the circadian tide turns at its nadir around 4 AM, the distance between process S and process C is small enough that we wake up and begin the cycle once more. Now consider what happens as we head into the night shift. You can probably see where this is going. So as we begin the night shift, process S will still be on the wake up, even if we have managed a successful little nap in the afternoon. Process C, meanwhile, is on the way down towards its lowest point, that nadir around 4 AM. So for a 9 PM to 9 AM night shift, this means that the distance between process S and process C will constantly be increasing for the first part of the shift, progressively lowering our wakefulness. It is this high burden of accumulating sleep pressure, rather than circadian desynchronization, which makes the first night shift feel so bad. The interplay between process C and process S also explains a couple of other night shift phenomena which most shift workers in the NHS will recognise anecdotally. That's the witching hour, or hitting the wall around 4 AM, and that feeling of the second wind when we feel like we actually have more energy for the last part of the shift as the sun starts to rise and these light cues, which the Germans call Zeitgebers, from outside combine with our rebooting circadian wake drive to help us temporarily feel better and function better, despite the fact that we've actually been awake and working for an overall longer period of time. So, using this knowledge of physiology, what steps can we take to help us minimize the risks for working at night and to help us keep our patients safer? So, there are 4 key areas. What we do before the first night, minimizing the sleep debt, that sleep deficit. What we do during the night to enhance patient safety. What we do between our night shifts to again minimize our sleep debt, and how we return to normality after the night shifts are done. So, but before the first night shift, the goal really has to be to minimize the sleep debt, so that we've got a bit less sleep pressure an urge to fall asleep once we started working. So on that first morning, don't set an alarm and let yourself sleep as long as possible. And avoid caffeine early in that morning. The reason being that if caffeine is taken, even tea, which rather than coffee, which does still contain some caffeine, it can be harder to get a good quality nap in the afternoon because caffeine's actually got a really long half-life in the body. So when you get to the afternoon, it's really important to try and have a nap, and ideally in multiples of 90 minutes, which is one sleep cycle, to avoid that horrible feeling of waking up between sleep cycles. During the nights, the goal is patient safety, so plan breaks within your team and create self-checks for safety critical tasks, such as prescribing potassium, insulin and anticoagulants, and beware that witching hour around 4 to 5 a.m. where the sleep pressure is really high and the circadian wake drive is right at its lowest point. So between the nights, again, it's difficult, but you've got to try and maximize the sleep that you get. So basic sleep hygiene is important, limiting screen time and not having any alcohol. Trying to invest in having blackout blinds and curtains, or even a sleep mask and eye mask. And if you do wake up in the daytime and find that you cannot sleep, get up for a short while, read a book, listen to the radio, but do try to then sleep again. And after nights, the goal has to be to return to normality. Rather than trying to stay up all the day after the last night shift is done, it's better to have a short nap for a few hours, 3 hours, 4.5 hours, when you first get home, and then force yourself to get up. And although this can be unpleasant, hang in there, do a bit of light exercise, and then try to go to bed at a normal time on that day. There's one last area about working on night shifts that I think is really important to discuss. And this is the risks to ourselves as healthcare providers in whatever profession we're working in, if we're driving home from the hospital after night shift. And the news clippings that you can see on the screen here relate to the sad case of Dr. Ronak Patel, who was a trainee anaesthetist who was killed driving home on a night shift in 2015. The Royal College of Anaesthetists conducted some surveys which give us some interesting information that illustrate just how risky it is for healthcare providers to be driving home after night shifts. So 57% of 2,231 UK trainee anaesthetist surveys had had an accident or a near miss on their journey home after a night shift. And in a subsequent survey, which featured consultants this time rather than trainees, 45% of those responding said they had had an accident or a near miss commuting whilst fatigued. But really interestingly, 72% of these incidents occurred whilst they were still a trainee, which tells us that this is when we are at the early stages of our career, when we are most vulnerable to having these kinds of accidents. And I'll finish with this note from Professor Walker in Why We Sleep that says, if you're drowsy while driving, please stop. To carry the burden of another's death on your shoulders is a terrible thing, and ultimately, it is just not worth the cost. So I do strongly think that if there's any alternative way to get home after a night shift, it's really worth considering. So thank you for listening to my talk about the night shifts. And if you found it interesting, there's lots more detail and lots of interesting other topics too about working as a young healthcare professional in my book, The Bleep Test, How New Doctors Can Get Things Right. Thank you very much for listening, and I hope you enjoy the rest of the conference today.
Good morning, everyone, and welcome to the National Health Careers Conference 2023.
Hi, my name is Nat.
Hi everyone, I'm Amy Robson. I'm the Deputy Director of Personalised Care at NHS England. I'm a physiotherapist by clinical profession and working in this strategy and non-clinical role in NHS England nationally.
Hi there, I'm Dr. Freddie. It's great to see so many of you here at the Health Careers Live Conference 2023.
It's always a delight to meet with you, and I hope today's session will be useful.
Maybe you're attending today thinking, okay, I know I want to do this job in the NHS. It might be that your eyes are open today to some other options as well that look really exciting to you. Or you might have joined thinking, I want to work in health, but I've no idea what I want to do. So, for you, this day is perfect.
Why is diversity in healthcare important? And I just want to touch on three main things that I think are really important when we think of diversity in healthcare.
We know that GPs look different to people now. People perceive GPs slightly differently. You mentioned earlier about how the pandemic has had a huge impact on how we operate. We see that our patients are becoming more and more complex in the way that they present.
We set ourselves a target to eliminate disproportionate referral and eliminate differential attainment in education.
To me, personalised care is both the middle of that continuum, as well as the ability to meet the person where they are in that moment of time.
It's always great to be able to kind of open people's eyes to the range of roles in the NHS and the range of routes in, because there is so much more than you might be aware of.
It really is inspiring to know that there are so many options to progress and to really put your passions across in healthcare. We're glad to announce that next year's conference, the National Health Careers Conference 2024, will take place on Friday, the 5th of July next year. So please do keep an eye out over the next few months on our social media pages. Thank you very much for attending.
Hello again, everyone. And for those of you who have been with us from the start of the day, you may be a little bit tired of me by now. But I hope this session is still very useful for you. This is for international medical graduates, and it's a Welcome to UK Practice taster. Now, this is albeit designed for IMG's international medical graduates. There are themes that are relevant to whichever healthcare career you are interested in. And you may be pleased to know as well that the NMC are doing something very similar now. We work with them to produce it, as are the HCPC. So whilst not everything will be entirely relevant if you're not a doctor, there will be some relevancy. So please do stay whatever your healthcare career. So I want to start by giving you a huge welcome. Whether you have been here a little while, whether you're thinking of starting, welcome. You make such a huge difference. If you were on the earlier session, I mentioned the huge difference that international graduates make to UK practice. And I mentioned that I've been doing some research for a book on anti-racism in medicine. And one of the things that I learned actually last year from the work on that is that geriatrics, the way that we have it here, would look very, very different if it hadn't been for international medical graduates who created it, essentially, based on their learning and style of practice in their countries of qualification. So it's essentially Indian, as it happens, international medical graduates who created geriatrics as we know it. So, welcome and thank you for the dedication, the insight, the care and compassion that you bring to patients and colleagues in the system every single day. Okay. So, by way of very brief introduction, in case any of you have joined, this is a first session with me that you're joining. I've been in healthcare for about 25 years now, and I've worked with survivors of abuse for years. I still do a little bit of that, but my day job now, if you will, is at the GMC, where a number of years ago, I was asked to set up a support centre for doctors on the ground. And I remember at the time thinking it was a really progressive thing for a regulator to do. It's not something that I had seen in my own MDT, in my own multidisciplinary team before. So I jumped at the chance. But I quickly realised whether it was UK graduates or international graduates, we were beheld in quite a lot of fear. And that was crystallised for me when I was once introduced in the early stages of my role onto the conference podium to the theme of the Imperial March. They actually embedded that into the PowerPoint. And I understand why. We are predominantly thought of in fitness to practice terms because it's about livelihoods ultimately. But as I learned much more about what the GMC do, because at the time I didn't know that much, of all our statutory functions, the ones that we have to deliver by law, I quickly realised that there in the centre, standards, that is the absolute fulcrum of what we do. And I would argue much more important for patient safety, actually, than fitness to practice. Why? Because the really serious fitness to practice stuff that we see applies to a tiny minority, fewer than 0.025% of the register. And that means that morally, most importantly, but also logically, the more that we can do to support colleagues on the ground to deliver challenging standards in challenging times, and, you know, that's been the case for a long time, challenging times, you know, well, that's where we need to be. And that's what the team that I helped set up are now known as GMC Outreach, and that's what I head up the operations for. That's what I co-lead, and this is what we do. I won't labour this too much because some of you certainly, I'm sure, will have been here earlier on in the day. But the bit that is particularly relevant to you as internationally qualified graduates is that last bullet. So yes, my team are there on the ground delivering supportive interventions, one of which is around international graduates. But the history, if you will, our origin story of doing work for international graduates comes partly from my team, because when we were out on the ground listening, delivering interventions and engaging with different groups, one of those areas we were consistently hearing about was the experience of international medical graduates. And in order to deliver true upstream regulation, i.e. preventing harm, rather than just, you know, sanctioning people at the end, the downstream end of the process, we needed to do a lot more. And we felt the system needed to do a lot more to provide support. So that's upstream regulation. I think it's particularly relevant to what we do to support international colleagues. So with that, I'm going to share a list with you. And as you look at this list, I want you to have a think about what you think it represents, okay? And feel free to type in the chat. What do you think this list is? It's a real list. I'll have a quick look at the chat. But don't worry if it doesn't strike you straight away. Now, a lot of people, when they look at that list, when I play it in a room, for example, at a conference, a lot of people will start laughing and saying it's StatMand, so statutory, mandatory training, e-learning, etc. In this case, this list was, well, I mentioned her before, my friend who qualified in Sudan and started working here not that long ago, 2016. This was the gamut of her induction. This is all she had. And then it was like, you know, you're safe to be on the wards now. No welcome. No welcome to the NHS. Thank you for bringing your skills here. This is how it all works. It's quite complicated, isn't it? Let someone explain it to you. This is what the different patient expectations are. These are the different medical, legal, ethical things that you might need to know about. This is how the rather interesting IT systems work, by the way. Where was the support? There wasn't any. And I talk about support for IMGs, but I want to be really, really clear on one point. I cannot emphasize enough that the deficit is not in IMGs. There is a strong evidence base to demonstrate that the deficit is in our system. There are data and lived experience that prove that point. We are not meeting the Maslowy stuff, as I like to call it, colleagues' basic needs. You know, if someone is coming here and doesn't have accommodation, doesn't know how to set up a bank account, doesn't know how the payslip works, those basic needs, how can you flourish? How can you thrive without that? If you are recruiting international colleagues, then it is incumbent on you to provide that support from signposting to, well, actually a lot more, because some organisations that are doing a really good job are doing all kinds of things like having language cafes and driving lessons, because it can be so different here, etc. So they need to explain not only support with that culture shock, but also explain the differences in the system. And if they don't do that, the deficit is in them, not our IMGs. And we were hearing all kinds of terrible stories, a bit like my friend, but even more extreme than that. You know, no welcome, no hello, no introduction, thrown onto the ward straight away. No explanation of how equipment might be a bit different. So, for example, one IMG I met during one of our focus groups wasn't told that, well, in where he practices one unisex catheter. Here, of course, we have male and female. And he wasn't told. Put on a male ward, the cupboard had both male and female catheters. Now, how eminently preventable was the potential catastrophe there? So back in 2011, we called for the system to create an induction for IMGs, but unfortunately there was no ownership at the time. Everyone agreed it was a good idea, but didn't have the resource or felt that it sat with them per se. And whilst it's not in our regulatory remit in that we can't mandate that type of induction, we did decide we needed to do something. So we created our own. And that is Welcome to UK Practice, which today is a taster session of. You know, it's a half-day workshop. We also have a full-day one that is back in development. It used to be full day, but a lot changed, as you might imagine, over the pandemic. And this workshop, well, I'll tell you more about it as we go through, clearly, but I cannot recommend enough that you sign up and join it. It's free. Delivered online, but also in person. Fewer in-person events, but that's because we find that it's more accessible for people online, although I have to say I really love the in-person ones. But yes, if you have a look on our website, then you can sign up. You don't need to be registered, for example. But my question for you, I'm using Mentimeter again for those who were at the last workshop. You may, if you're at the very first one, know the answer to this. But if I can ask you to grab your phones and type in menti.com, it will give you a page to allow you to enter the code that you see there at the top of the slide. So if you would do that, and I'll just give you a few moments to get on. I'll see if anyone was there and remembers the answer. Okay. Okay, we've got one person connected. I'm not going to say anything. Of course, I don't know which of you were at previous sessions. I should have thought this through, but I was thinking that this session might just be for IMG colleagues who weren't at the previous session. But I'll put you out of your misery. 5 of you have either guessed right or were at the previous sessions. And remember, yeah, there has been exponential growth of IMGs joining the register. And that means that support is even more important. It was important back in 2011 when we called for it, but now it's even more important. And what Welcome to UK Practice does, it takes you through good medical practice, which we ran a workshop on earlier. And my next question for you, good medical practice, the standards that we have, how many pieces of professional standards do you think we actually publish? Is it just good medical practice, or is it more than that? What do you think? And these are all the ethical pieces of guidance, so not things like revalidation, because that's just, you know, this is a process, etc. Here's some advice and support. These are the medical ethical pieces. It's always interesting to see how this moves. Ah, there we go. I was waiting for at least 2 people to have it. Yes, so 2 people have it. There are 31 pieces of medical ethical guidance. Yeah. Some of you may have heard about how sometimes people feel that it's common sense and obvious. And what we're going to do in this session is explore the much more complex themes, which I alluded to earlier. And in the real half-day workshop of Welcome to UK Practice, we delve into these in much, much more detail, as you can imagine. It's a highly interactive workshop based on video ethical scenarios where you really explore the detail around shared decision-making and consent, around raising concerns, around confidentiality, around Gillick competency, all sorts. So that's what the full session does, but I'm going to give you a flavour. And as I say, you'll see that the standards that we really go through with you there is, are very much more than common sense. And this next slide, which is a bit horrible, and I don't expect you to read, that's the point of the slide. This is a list of every single piece of legislation that we distilled to put into just one of those guidance documents. And that's the confidentiality guidance. So that just shows you that if you didn't have that guidance, you'd need to know technically about all of this legislation. Whereas what we do with all our guidance documents, we look at the relevant UK legislation, we look at the wider ethical framework, and we take out the salient bits of the legislation and put it into a more digestible document for you, which can act as a reference guide as well as as well as really helping you through the more complex scenarios that you may see. So we'll start with one that's not quite as complex, but gives you a flavour. So in this case study, I want you to meet Sally, and I'll let you read that. And just whilst you read that, have a quick look at the chat. Okay, so hopefully you've had a chance to read that now. And my question for you is, in this scenario, let's say that you are her GP, okay? So you've got a good rapport with her, you know her quite well, and she wants to, understandably, speak with you about her diagnosis. In this scenario, though, she's asked for that video consult. Is that appropriate? I was just about to say everyone's going with it depends, but someone's gone with yes. Yeah. Now, of course, in real life, you would know much more about Sally. You'd have a lot more detail than 3 boxes of high-level information. But yeah, so you may have made the assumption as you're answering yes or no, you may have made assumptions. So those answering yes, you may have made the assumption that actually, she said that I've got a good rapport with Sally. An initial consultation by video might be fine. You may have made the assumption that the Sally that I've made up in my mind, I really need to see her in person with what could be a really difficult conversation. Or if you've answered depends, you might be thinking, well, it depends on those things, doesn't it? So what do we say in the standards? They're high level. However, there are detailed elements that can help you with the decision. But the principle, the core principle is high level. Of course, you must provide safe and effective clinical care. That can be done remotely, but it can be done face to face. So it depends on your professional judgment. And earlier in one of the sessions, I said that good medical practice is designed to allow you to exercise your professional judgment, because a booklet of ethical standards can't describe every scenario, but it can provide high-level principles. Now, in addition to those high-level principles, we do provide that support with decision-making. So when it comes to making a decision on whether a remote consult is appropriate, then we've got things like this flow chart. And don't worry about trying to read it. I don't know how small the screen is at your end, but it's a screenshot just to show you that it exists, and it's interactive and you can find it on our website. This is just one example. We have these for other complex areas as well, such as safeguarding. And what you can do using these tools is you can look at the duties, you can put in the relevant bits that it depends, those bits into the equation, if you will, to go, okay, this is what the standards say, and in this particular circumstance, I do think, or I don't think, a remote consultation would be okay. So my point really with this scenario is to introduce you to the fact that there are loads of resources that we have in addition to the sort of booklet, digital booklets with the standards. There are also there's also an ethical hub that has all sorts of things, from case studies to decision-making tools, to offer that additional advice, if you will. So do avail yourselves of that. Again, you don't need an account or anything to access all of that. Now, the next scenario that I want to take you through is a little bit more complex. So meet Talia. Talia is a composite of many of the clients that I used to see. And I'll pause and let you read her scenario. So again, obviously there's a bit of a paucity of detail here, and you would have a lot more with Talia actually in front of you. But there are some important points to remember, I think, other than the very obvious, and that is that she has chosen to represent. She's chosen to re-engage with sexual health services. Okay. And yes, there are all of these issues going on. It showed she is subject to domestic abuse, and in conversation, she does confirm that yes, she is still subject to domestic abuse. This is not historical. Okay. You try and explore with her about sharing that with adult safeguarding or with the police. And as you were building a bit of a rapport with her, you can see that she visibly withdraws then. She closes up. She's quite clear, no. She's adamant, no, I don't want you to do that. So to continue the rapport building, you don't want to press. You don't feel you can press at that point, because clearly you want to support her with treatment. You do try and explore the GP question as well. And again, she's adamant that she doesn't want her GP to know. And again, she doesn't want to engage in that bit of the conversation. You try broaching disclosure to her partner, and that is where she looks frightened. So that's the situation in front of you. And my question to you, and the language of this question is important. Do you have to breach Talia's confidentiality? What do you think? And it's in scenarios like this where I defy anyone to tell me that good medical practice, our standards and guidance are common sense. This kind of situation is never common sense. It's never easy. And as you can see, we're 50-50 split. Someone's, you've now broken my 50-50. But as you can see, there is quite a diversity of opinion. Okay. But the majority of you are saying no. And the majority of you are right. You don't have to. Now, of course, that doesn't mean you're not going to explore things with her. But I'm going to take you through the decision-making process. So what the guidance would do, reading the guidance, reading the standards, you would see that when it comes to sharing information, when it comes to considering considering sharing confidential information, there are 3 elements that you need to consider. And a lawyer rather interestingly came up with the mnemonic clap to help teach, a lawyer teachers came up with that mnemonic, which I think is particularly entertaining when you're talking about sexual health, but that's an aside. And that mnemonic is, well, the obvious one. Have you got consent? So in this, applying it to Talia, have we got Talia's consent? No, we haven't. So we can't share information based on consent. Does the law require you to share information? And this is really interesting because people will talk about the laws around reckless transmission, the Care Act, etc. And actually, the law, as applied to a scenario like this, a case like this, it does not require you to breach information. So where does that leave you? Because as a doctor, as a healthcare professional, have you got a responsibility as well for the wider public, that wider public interest? And that brings us to the public interest test. So with the public interest test, and by the way, I use my phone to run on the slides. I'm not just randomly looking at my phone. With the public interest test, there are various elements to consider. And the first two, the more obvious ones, are these two. So I'll let you just scan that. So we're weighing these two things up and applying it to Talia to make it tangible. You are considering benefits to an individual or society in breaching Talia's confidentiality. So that would be the benefits to her partner. Clearly, he may well have contracted HIV and there is a benefit to him getting treatment. And indeed, he might be sleeping around, she might be sleeping around, it might have had other issues which mean that there is wider societal benefit in breaching Talia's confidentiality. You're weighing that, of course, against the harm to Talia. This time, he might kill her. However, there is something else that needs to be considered on this side of the scales, where you can see I've left a bit of a gap there. And I wonder if anyone knows what the other element that you must weigh needs to be on that side. And I'll give you a few moments to have a think about that. It's not an easy one. And I've run this case with very senior experts in the room in the role that I used to have more as my former day job. We would talk about scenarios like this for hours. Yeah. So I'm reading the comments now. Yeah. Do patients here feel pressurized to share? How do we create safe space? Oh, really good points. The thing that is missing is you also need to weigh that wider public interest in having a confidential medical service. And that, I'm not saying that makes it easy, by the way, and I'll come to how we apply this, as I say, specifically to Talia. But it does tell you all the considerations that you must have in mind. Okay, so you must have in mind the benefits to wider society, like Talia's partner, the harm to Talia, but also that public interest in that confidential medical service. And what I mean by that is, let's say your service, whether it's a GP practice, whether it's a sexual health clinic, and it's happened a lot with sexual health clinics historically, let's say that service gets a reputation for being leaky with confidential information. And what might happen? Patients might stop presenting. And as I say, that has happened before. So that is something to weigh into the consideration, because, well, I'll tell you, in fact, about a patient, a case that we had where our client, she was raped at knife point, and she came to us for forensics, a health check, and she didn't want that information to be shared. Okay. The place where it happened, the location geographically, is somewhere where people visit quite a bit. There are significant risks to the public there. The person who came to us was someone with quite a high profile. And she said that, look, I need, in order to cope, I need to forget about this, and I need to work with my therapists, counsellors, etc., to do that. I cannot have this go public. I cannot have this shared with the police. I cannot have them asking me questions. I need to try and move forward. So please do not breach my confidentiality. If you do, I will go to the press and tell them how unsupportive you are as a service. So you can now see, I hope, how that makes this very, very real. These black and white words that can be a bit abstract, how it makes it very real. So whenever you have this kind of, and I am talking about really, really complex cases, and of course you will have really complex scenarios, but whenever you have something like this, what do? You look at the standards, you apply those black and white principles, but as I say, it doesn't make it easy. You know, at least it tells you the shoulds and musts that you need to consider, but we all have our own biases. I know where my biases are, for example, in the Talia case. And there isn't room for our biases. So that's why, as I mentioned, we used to have really long conversations about these complex issues to sense check our thinking. There are also medical defence helplines, etc., to, again, help sense check our thinking if you've not got the information to hand, immediately. So that's what I would suggest you do. You know from our standards, and don't bother necessarily trying to read this page, but it just shows you, well, hopefully it will when it moves on along in the slides. It shows you what you should and must consider. All right, I'm just going to give the slide a nudge because it seems to have stopped responding. There we go. Right. Yeah, as I say, don't bother trying to read this now, but it just shows you the kind of information that we've got in the guidance. So you are clear on what you should and must consider, but then always sense check with colleagues when it is that complex decision. When it's not an emergency, you've got time to explore that. And bringing it back to Talia. So what I would do in Talia's scenario, as I said, one important feature was that she has represented. She wants treatment, having re-engaged. You are building a rapport with her. So we've got some time here, and there are all kinds of things as well at play. So, for example, you don't know whether she contracted HIV off her partner, off her abusive partner, or maybe he has off her. Now, different factors will influence your decision in different ways. If she had children in the house, either subject to or witnessing the domestic abuse, that will change the weight on the scales. If she's got a zero viral load, which she won't have because she was lost to follow-up, but if she did, then that would change the weight on the scales. If you think with her in front of you, she really does want to stay engaged with services. I've built a good relationship with her. I think I've got a couple of months where I can work with her to persuade her to access adult safeguarding services and thereafter do a notification to a partner. So that's the approach I would take for Talia. The approach that we took for the survivor of rape that I mentioned was that we told the police what happened but didn't give any personal details. They weren't very happy with us, but they actually did up their presence in that geographical location, that very particular location where many women would have been at risk. So anyway, use the standards to sense check, to weigh your decision making, but also when it is something terribly complex, sense check with colleagues as well. You can make calls to adult safeguarding who have lots of expertise in this area. You can make calls to medical defence if it's, let's say, midnight and it is a more urgent decision. And there are learning materials available as well to help you get more practiced in these things. So we've done that. So coming back to the standards then, as we start to wrap up ahead of questions. So the standards, good medical practice, our decision making and consent, our confidentiality, our end of life care, all of these standards, what they are, as I said earlier, way more than common sense. They are that benchmark for that good practice. And they're that safety net as well. And I don't mean that in a defensive practice way. I mean that in the sense that it's a safety net for Talia and you for really, really complex situations. So use it that way. It's supposed to be there to support you. And you, whatever your profession, you will have ethical standards. For example, the NMC has the code. But as I mentioned, the GMC, we've got 31 pieces. So we do go into a lot of detail. And I know, for example, when I used to work in end-of-life care more, a lot of nurse colleagues, palliative care nurses, used to use our end-of-life care guidance very, very heavily. So all these standards, whatever your profession, they are medical ethical standards, but they are relevant. So feel free to use them. Of course, you need to follow the standards that your own professional regulator produces, but these are all in line with the wider ethical framework and UK law. So to summarise, the standards, therefore, offer that benchmark of expected practice way beyond common sense, but they offer that safety net. And for those of you who were in the anti-discrimination sessions earlier, they offer that lever for change as well. They can offer that lever for change in very practical ways. So going back to end-of-life care, I will always remember one organisation that instituted a... because of the culture, they instituted a way of working that meant that people weren't really following what they should be around DNA CPR. And they used our end-of-life care guidance to take it to the, as it happens, the Director of Medical Education and say, hang on a minute, the ways of working that we seem to have adopted don't allow us to follow the standards. And that allowed them to change the ways of working to ones that were much more compassionate, actually, and supportive of patients, those close to them, and the team. So, to wrap up, please do join us at Welcome to UK Practice. We know that the course works. It will take you through many more scenarios that we know are particular challenges for IMG colleagues. And as you can see from the feedback here, people do love it. The last couple of bullets are academically robust evaluation, which show unusually for a one-off medical education intervention, practice has changed at time to follow-up. We've got loads more support for IMGs as well. So yes, we've got Welcome to UK Practice, but we have one tailored to primary care. We have a follow-up called Thriving. One challenge is that we find employers often don't know who their IMGs are, so they don't get released for attendance at induction, trust induction sometimes, but it's certainly not Welcome to UK Practice. So we've got a dashboard and we speak with employers and say, look, are you releasing your IMGs? Here's your list of IMGs. You need to release them so that they get a supportive induction. I mentioned in a previous session earlier on today about cultural competence for supervisors or cross-cultural communication. We've got a course around that because supervisors, those our IMGs work with, they themselves need literacy in how to support IMGs. So we do that as well. And of course, any other outreach workshops that we deliver. So that's all great. That's what the GMC do. I've also signposted you to the fact that we have loads on the website. However, our stance, and this goes back to what I was saying in an earlier session today around employer responsibility. And it was something that I actually said on Twitter last night. If you can't afford to provide proper, welcome, comprehensive support for an IMG, then you can't afford to employ an IMG. And we want every employer to implement these standards for them. We can't mandate it. We drew these up in conjunction with the indefatigable, marvellous Prof. Marla Rao, NHS England, the BMA, Medical Protection Society. So we all want this rolled out. But at the GMC, personally, we don't have the power to do so, but we hope every organisation does implement this. So that is it from me. I think we have a little bit of time if there are any questions. So I will pause there and see and have a scan of the comments. And thank you, team. I see the team have shown you where you can book your place, etc. as well. Okay. Yeah, and our exhibition stand does indeed have resources, so you can look at the exhibition as well. Thank you so much. I hope that was useful, and I will leave you with another emphatic urge to go and book onto Welcome to UK, and we hope to see you there. Thank you very much. Bye. The NHS would be very different without you.
Join an amazing team of registered nurses working within healthcare. Technologies are going to be a key enabler to moving healthcare systems forward.
Thank you for those sessions from Luke Austin and Tista Chakravarty-Gannon. It's time for another short break now, with lots of workshops still to come. We have Sue Howard talking about pathways through health and care careers, Jamie Bytheway discussing widening participation and support for your application, followed by Andrew Ferber, OBE, with his talk titled How You Too Can Make a Difference, a Fairer, More Equal and Healthier World. Lastly, we have Professor Subodh Dave with a session called NHS Heroes Need Help Too. Don't forget to check out all of the resources on the website in the meantime, and all sessions will be available to watch back following the conference. Enjoy the break, and we'll be back shortly.
My name is Sue Howard, and I'm just going to spend about 10 minutes sharing some of my insights with you about pathways into health and social care career. Just let me bring up the slides. So I work at NHS Greater Manchester, which is the Integrated Care Board, in the People and Culture function as Head of Workforce Development. And I am hopefully going to share with you just some of my insights today in terms of my own career journey through the health and care system along the way so far, and give you hopefully some really helpful tips to help you onto the health and career path, and perhaps help navigate through your career as you move forward, just from my experience, and providing some tools and approaches that you might want to consider, and some resources that are available to us all. So the first thing to say is, historically, career pathways in the health and care service tended to lean towards being quite linear paths. So you'd start at the bottom and work your way up and spend your career in one particular space, and that just doesn't seem to be the case anymore. Many people chop and change along the way, do something different, and that seems to be increasingly the case in many organisations. And one of the things that we look at in our workforce development portfolio is, how do we retain people? How do we keep people in the health and care service? Things may change for them, they might want to do something different, but we want to retain their skills and experience and enthusiasm. So how can we keep them in there, but allow them to do something slightly different when things change and they want to try something new? Portfolio careers, again, also getting increasingly popular. If you use an example of general practice, lots of general practitioners now have steered away, or more of them have steered away from becoming a partner in their practice, and instead do X number of sessions per week, and then maybe have some additional responsibilities alongside. So for example, they may have quality improvement interests, or they may have a leadership role, and they do this alongside their caregiving as a general practitioner, and that they have really paved the way for portfolio careers. Many other professions are also giving this as a greater opportunity now for people to not just change the journey along the way, but actually even in the working week they might do a bit of a mixed portfolio, which is another great opportunity. So this is a infographic that we helped produce for some social care colleagues that we work with, just to give a bit of a snapshot of, moving your way through. How do we support people to see what opportunities there are available as they progress their careers? And this is just one snapshot of social care, but there are over 350 professions in health and care service. So the options really are almost limitless about what opportunities are available to people to move around and to do something a little bit different. For looking at it from a professional's perspective, one of the tools that I've been involved with developing over the last year or so is a recruitment and retention toolkit. This is for Greater Manchester, and it draws on lots of the national and wider resources, but also builds on a lot of the case studies we have from within our footprint, because we have some brilliant work that's been happening to look at different ways of approaching getting people into the health and care service, and how do we retain them better at the back end as well. There's also a national programme that is also resourced within this toolkit. You're welcome to have a look. I've included the link there, and it's really quite inspiring about some of the alternative approaches that people have taken to bolstering the numbers of people that are working in health and social care. So when I was reflecting, preparing for this session, I was thinking about my own career journey and how can I share some of the learning from that journey that I've taken to help people either into health and social care or to help develop their careers as they move forward. So I've come up with top tips, just 5 of them, that really have been quite pivotal in my own career journey, and I think are key things that other people might want to consider on their own journeys as well. The first thing to say is that don't give up at the first rejection. It's often quite difficult to get into health and social care in some professions initially, but if you keep at it, you will get there. I considered myself to have done reasonably well in my career. I'm really proud of where I've gone to, but it could have looked really quite different because I absolutely bombed at my A levels, completely and utterly. And so I managed to scrape my way into university. I did biology, and the rest is history, really. So that was a really big life lesson for me. So I would say that, you may come across some hurdles, you may have some failures along the way, but do not give up. If you keep at it, you will succeed. There is help out there, and actually my experience is if you do call out and say, can you help me, I really want to do this, I'm really enthused, people generally will help you. So if you do reach out, the help is there to get you where you want to be if you've got that interest. I've included a link at the bottom, linking in some of the national resources that are available to help you with your CVs and applications, etc., interview practice, etc. And I've also included a link to the recruitment events that I mentioned, because there are some great tips for professionals there about how we might do this better, and how we might get some of the local people, local populations into health and care service that may not have considered or been unable to get into the sector so far. There's some really brilliant ideas about how you can remove some of those hurdles that are there for people, relatively easy to open up this world of opportunity. My second top tip is to do what really interests you. So when I finally achieved my degree, I decided that I really fancied doing some laboratory work because I really love the practical side of my degree. And once I started a job in research, I then realised that I really missed the infectious diseases element of my degree. So I decided to take up clinical scientist training. I didn't get there first time, had to apply a few times, had to battle at it, but I got on there, and I had several years of absolutely loving clinical science. I really loved that. I had such a good time. And I think that my reflection on it is, and this is along the way, if you're doing what interests you, you're much more likely to succeed. They do say that people that are experts in the field, people that win the Olympics, become, internationally renowned musicians, whatever their profession might be, that those people have put 10,000 hours in to become experts. So the more you put in, generally speaking, the more likely you are to get where you really want to be and to maximise your potential. So I was definitely doing what I loved at the time. Then I had one particular year that was a really challenging professional year, just lots of things collided at once. And I came out of it a different person. And my reflection was that I didn't feel that I could wait 10 to 15 years for somebody to retire to get where I wanted to be. I was ready for progressing, and I would just have to wait because of the nature of the beast till that people moved on and people retired until I could progress in my career. It was one of those jobs for life. So I spent about 6 months wrangling about it, but I actually did leave clinical science. It was so unheard of at the time. Someone from the national team rang me up to say, why are you leaving? But I took this massive leap, what it felt like to me, to leave clinical science and to do something really different. And so I went into research and did some translational research for a number of years. It was really scary, leaving behind my career for life, my comfort blankets, my knowledge base, and do some stuff that felt really scary, but it was a brilliant opportunity, and I never looked back, and I'm so glad I took the plunge. I traveled the world sharing my data and had some fabulous experiences and built up some amazing skill sets. So yeah, definitely don't be afraid to take the plunge and do something different if it feels like the right thing to do. Then acknowledging that things can change again, and several years down the track, I was reaching my late 30s, decided we wanted a family, and therefore commuting at that time for 3.5 hours a day and doing 48-hour experiments through the night seemed a bit less appealing. So it was time to adapt, to change, and to do something different again. And so at that point, I decided coming back into the health and care service more directly was what I wanted to do. I had been doing research to support clinical care, but I wanted to be closer to making improvements in health and social care directly. So I worked for an organisation that was the connector between academics and health and social care, and did lots of implementation and evaluation. And that was a brilliant experience. And I had adapted to my own personal circumstances changing, but it gave me a whole raft of new experiences and skills to build on. And again, that was a scary experience, leaving behind that knowledge of that particular specialist area that I'd been working in by then 15 years. But it was a brilliant opportunity, and again, I didn't look back. And finally, and this is where I suppose I am at the moment, is I've now working at a system level, a system leadership, and I have pieced together all of those experiences that I've had along the way, all of those lessons learned, and now work in a team, and I bring that wealth of skills and knowledge, experience, and the networks that I've built up along the way as well to the team that I currently work in. I've got a really mixed team. I work in a people and culture team. There's obviously a lot of people that work with a HR background, organizational development, but we've got people that are parliamentary background, obviously clinical science, research, physiotherapists, people that worked in local authority. There's a real range of people, and I guess it's just to frame the opportunities out there are huge, and you may be unaware at this point where you might see yourself in 2-3 jobs down the line. But there are really varied roles out there that are looking for people that have got varied backgrounds and varied experience to bring to a mixed team. And I have so far had a brilliant career trajectory. I've enjoyed every single role that I've been in. I've enjoyed every single role that I've then moved on to. It's been the right time to do something new. You know, who knows, watch this space in the future. I've got a few jobs left in me yet. But hopefully these top tips and my experiences will help you on your journey into getting into health and social care and progressing through it. There are almost limitless opportunities. As I said, 350 professions. You can chop and change, you can move around. Once you're in the health and social care service, you start to build up a network of people that you can call upon, that gives you those opportunities to do something different. It's really an inspiring place to work. It can be such a great opportunity to have a whole career in health and care service and give back also, which many of us have come into this in the first place to give back to patients and make it a better place and give people better health and a good life balance with their health. So I'll pause there. Thank you for taking your 10 minutes out to listen to my experiences, and hopefully some of these top tips have been really useful to you. Best of luck in your journey, and all the best for the future.
The NHS would be very different without you.
Join an amazing team of registered nurses working within healthcare. Technology are going to be a key enabler to moving healthcare systems forward.
Hi everyone, my name's Jamie and I'm the Head of Writing Participation for Manchester University NHS Foundation Trust. I'm going to talk to you a little bit about alternatives to in-person work experience in the NHS. As I'm sure lots of you will have found, work experience in the NHS can sometimes be quite hard to come by because it's very, very high in demand, and we have lots of different learners that we support within the NHS. So I'm going to give you some tips and tricks to look at alternatives where you can still get really valuable experience, develop your skills and increase your knowledge of working in the NHS, which will help you with either applying for jobs or applying for courses in the NHS in future, and also helping you decide what it is that you want to do. So for most NHS in-person work experience, each NHS organisation will do this in a slightly different way. Usually, most places you'll have to be at least 16. Usually you won't come in for more than a couple of days, maybe a week at most, or 2 at the very, very most. And actually a lot of it will be kind of shadowing and actually kind of just seeing different staff, watching them do their job, which can help you understand how roles are different. And it may be that you do get to have some interactions with patients, or you might be able to do some tasks which will help you develop your transferable skills. But like I've said, it's not the only way to do that. Most NHS organisations will also prioritise local students for their work experience offers. So we suggest that you get in touch with your very local NHS organisation and also work with your school and college career teachers to find out what work experience might be on offer in the NHS. But to come on to what some of the alternatives are, so the first alternative that I want to talk to you about is volunteering. Volunteering is a great way to get experience in the NHS and to kind of help you with your kind of future career goals and future aspirations. Again, most volunteering opportunities will kind of start at 16 plus, but they will expect you to make a longer term commitment to that opportunity. So it might be that you need to volunteer an afternoon a week, an afternoon a month for a year or longer to make that commitment worthwhile. For some volunteering roles, you will have to do a kind of formal application and interview. So again, you should spend a bit of time on this and thinking about what it is that you can bring to that role, why it is that you want to do it. And you may have to undergo some background checks like a DBS check. And you may also have to complete some online training before you can start volunteering. So it's a really good way of showing your commitment because the process demonstrates that you're committed to taking part. Within volunteering, there's lots and lots of different types of volunteering roles, and again, it will depend on your local hospital or NHS organisation as to what that volunteering looks like. But actually, through making that long-term commitment, you are demonstrating your commitment to a career in the NHS, and you're demonstrating your caring and compassionate nature by giving up your own time to volunteer to help others. You'll also be able to demonstrate how you've developed your transferable skills outside of school or college. So those transferable skills will definitely involve communication and teamwork, because you will be working with other people, maybe other volunteers, maybe other health professionals, maybe even patients. And you will also be developing your communication through having to talk to different people and really kind of show that you develop those skills outside of a school or college setting. So to find out about volunteering opportunities, again, you should go to your local NHS hospital website and search for volunteering, and information on how to apply will come up. The next opportunity that I want to talk to you about is NHS Trust membership. A lot of NHS Trusts will have foundation status, which means their members and governors have much more of a say in how they are run than just the government. So you can become a member of an NHS Foundation Trust at age 11. So for those of you that are not quite 16 and are not able to volunteer or get work experience, becoming a member is a really, really good way to, again, show your kind of long-term commitment and interest in all matters related to the NHS. So what does being a member involve? So you will get sent regular newsletters, regular updates, and you may get invited to take part into various meetings and consultations to share your views on how NHS services are being run and delivered. And some organisations may also organise specific open days and events just for their members or just for young people. So it's almost like being in a bit of a priority club where you might get to find out much more about what's happening at your local hospital, and that will help you get access to other opportunities where you might get to meet different types of staff, different patients, and again build on your skills and experiences. Through being a member, you'll be able to develop your understanding of what the challenges are within the NHS and how these are approached. And if you do attend any meetings or events and activities, again, you can really develop your communication and teamwork skills in that setting outside of school or college. So again, to find out about membership opportunities at your local NHS organisation, search membership on their website and you should be able to find out how to join as a member. The final type of opportunity that I want to talk to you about are either online work experience opportunities or other online or in-person experiences outside of work experience. So, for example, some NHS trusts will run careers events where you can come on site, meet different types of staff, take part in different activities, and these events usually tend to be half a day or a day, so slightly shorter than work experience, and you might not get to go into a clinical setting, you might be in more of an education setting, but you will still get lots of information about different careers. You'll get to interact with staff. It will help you with your decision making and help you develop the skills and experiences that you want to get through your work experience. And we do find that sometimes students will overlook these opportunities and think that they won't count towards work experience requirements for university, but actually they can be a really, really good way of you still getting that experience and helping you with your decision making. Additionally, there's lots and lots of information. There's so much information online about different careers in the NHS, from different videos and case studies to online work experience or mentoring programs. So again, your school and college should be sharing these kinds of opportunities with you. If you let your careers teacher know that you're interested in working in the NHS. But alternatively, you can do your own research, which again shows that you're being proactive, which is a really good skill to have when you're looking at going into the workplace or looking at doing university level study. So the websites that we would suggest that you look at would be the Health Careers website, which is the NHS national kind of health promotion website, where you can find out about all the 350 different careers areas that we have. And then also looking at different professional bodies and royal councils, such as the Nursing and Midwifery Council, the General Medical Council, the Royal College of GPs, Royal College of Surgery, or if you're not sure which professional body is attached to the career area that you're interested in, if you Google or search on the internet for the career that you're interested in, followed by professional body, for example, orthotics, that will bring up the British Society of Orthotics, which will again might lead you to find out about different career videos, different work experience, different programs. So again, we would always suggest that you do your own research around the career area, because you may find something that would help you get that experience that you need. And then finally, for those students based in the Northwest, we'd like to recommend the Creating Careers online programme, which helps you develop your understanding of healthcare and develop an online portfolio. So it's an online programme supported by a number of different NHS organisations where you will work through various different courses and modules, and then you will also get access to different online or in-person experiences once you've completed some of the modules on that site. So again, to find that opportunity, we suggest that you search for Creating Careers Northwest online. as I've stated, there's lots of different things that you can do to demonstrate your commitment to a career in the NHS, to find out more about which type of career would be valuable for you, and also to develop your transferable skills and experiences that you will need to make a good application either to a job in the future or to a course of further study. We'd also suggest you doing your career research, because you may come across your dream career that you were previously unaware of. Hopefully these tips have been useful and that you will take this advice, and we'd like to wish you all the best in the future, and hope that you join the NHS in the future. Thank you very much.
My name is Mark Radford. I'm the Chief Nursing Officer for Health Education England.
I'm Sarah. I'm a neurosurgery trainee. I'm currently working in Cambridge.
I'm Adrian James. I'm the President of the Royal College, and I'm really delighted to be here.
My name's Abby, and I'm the Careers, Information and Quality Lead for the NHS Health Careers team. I hope to be able to get across to you some of the amazing opportunities within the NHS.
We have got podiatrists, occupational therapists, speech and language therapists.
So we're going to talk about good medical practice, we're going to talk about protecting patient safety.
Because of restrictions, because of remote working, because of the lack of face-to-face contact, because we have to manage patients a different way, we've had to think differently about how we manage this work and how we use technology.
I'm in London, so good to see you. I think we've got Ian here as well, haven't we? Hi, Ian.
Hey guys.
We are not the only people who are facing problems, but actually through sharing those problems, we can become the health professionals that are required for the globe and for the NHS in the future.
It's been really interesting hearing all your top tips. I've got my list now. I can pack my bags. I'm going to wear my seatbelt for safety, but I am going to look out the window ahead of me and enjoy the trip.
It's just about us finding the greatness within us and bringing it out and being our best self.
What are you doing about self-care? Check out our free resources on health and well-being on our Health Careers Live website.
What a fantastic presentation and session we've had from the team just before us. Some truly inspiring stories and some great inspiration for all of us moving forward. At this point, we'd like to move on to the next session of the afternoon. And it's my great honour to introduce the next speaker, who is Andrew Ferber, OBE. So Andrew has been Regional Director for Public Health England and Regional Director for the North West since May 2020. He was previously Centre Director for Public Health England in Yorkshire and Humber. He originally trained as a GP and is now a public health specialist with international experience. He's worked for 7 years in Nepal at all levels of the health system over there, working on some short and long-term projects over there. And in the UK, he's worked as a public health director from 2007 all the way up to 2018. And he's previously been president of the Association of Directors of Public Health. So truly a well-accomplished man. Really, really fantastic. Andrew is so well accomplished actually that he was awarded an OBE in May 2022. So once again, it's my great honor to have him here today and have him on the program speaking. As a public health trainee myself, Andrew is not only an inspiration, but it's also my boss's boss's boss. So he's a true role model, and I hope to one day be able to achieve some of the things that he's achieved in his career and use him as the foundation to follow moving forward. Today, Andrew is here to talk to us about his journey through public health, the role public health plays in modern times, how people just like yourself can make a difference, and some of the career opportunities available to all of you sitting at home. Without any further ado, please welcome Andrew onto the stage.
Thank you. Yeah, it's good to be here today.
So how's it going, Andrew? And how are you feeling?
Yeah, no, I'm good, thank you. I'm looking forward to the weekend. It's been a busy week. It feels like autumn's arrived in the north of England. Looking forward to getting out and about in the weather.
That's definitely correct. The weather has not been beautiful where we are at the moment, but hopefully it doesn't last too much longer. We're very excited to hear you speak today, and I'm sure all those at home have been waiting eagerly for this session. So whenever you're ready, feel welcome to take it away.
Okay, thanks very much, Yaz. Can I just start by saying I really appreciate being invited to this event today. I think it's just fabulous what you're doing. We need to do so much more to improve access to medicine and other healthcare professions to ensure that those coming into the profession better reflect the communities that we serve. There are far too many underrepresented groups that are not represented in medicine and other healthcare professions. So I just love what this conference is doing and what work is going on more broadly to try and improve access. And if you're kind of listening in today and just kind of wondering whether you've got what it takes, if you feel passionate about a career in medicine or a healthcare profession, then my advice to you is to go for it, follow your heart. And if you've got the passion and you're prepared to work hard, you will make it. But following Yaz's very kind introduction, I do just want to talk a little bit about public health, and in particular how you can make a difference to a fairer, more equal and healthier world. I hope at the end of this, a better understanding of what public health is, and an understanding of public health careers. And if you don't think a public health career is for you, how you can make a difference to see a fairer, more equal and healthier world in whatever part of the healthcare system you end up in. But I wanted to start just by telling you a little bit about my story and my journey. So I went to Newcastle Medical School and was there for 5 years. To be honest, I'm not really quite sure I knew what I was letting myself in for. I was kind of good at sciencey things at school. I wanted to do a degree that was kind of more vocational than theoretical, and I had the grades for medical school, so I kind of went for it. It's kind of not the motivation I would recommend, or probably not the motivation that would get you in these days, but it's what got me to Newcastle. And through my 5 years there, I kind of really enjoyed everything and all the specialties that I passed through. So at the end, I decided to do general practice because I felt that kind of gave me a little bit of everything. I could do some pediatrics and long-term condition management, dermatology, obstetrics. You could do a little bit of everything. So that's what I started to do. But I did have a hankering to do something different while I was still young and still able. So at the end, or actually in the middle of my GP training program, I took 6 months to go and work in Nepal. And the picture you can see at the top right of the screen is actually Mount Everest. The peak at the top there in the middle is Mount Everest. And I spent 6 months in Okhaldunga district, which is the district to the south of Solukhumbu district, which is where Mount Everest is. And I was there at a district hospital covering between one long-term doctor leaving and the next long-term doctor arriving. And it was a real life-changing 6 months, a real career-changing 6 months for me. And I want to tell you about one individual in particular who I met there. Was a young lad called Sham. Must have been 10, 11 years old. And even though I was a relatively junior doctor, as soon as he walked into the clinic, I could see immediately he had what we call Pott's spine. So this is a deformity of the spine that's very often caused by tuberculosis. And we got the test done and confirmed that tuberculosis was the likely treatment. Now, the treatment for tuberculosis that we were using at the time involved an injection and some tablets, and we would normally teach the family how to give the injection and instruct them on how to give the tablets and send them back home to continue the treatment. If patients needed admitting to hospital, there were costs involved. Patients had to pay for, contribution at least towards some of the food, for example. It's not like the NHS where everything is free at the point of need. In situations like Nepal, these things have to be paid for in some way. So people usually prefer to go home and take the treatment at home. But anyway, this lad's father was absolutely insistent that he was admitted, absolutely refused to take him home. And so after some discussion, we agreed to admit him. And he was with us for about a month. And during that month, we got to know more about his story. And it turns out that this lad came from a village about 2 days walk away from the hospital. There were no motorable roads in the time in the district. People just had to walk to the hospital if they wanted to come. No ambulances, people had to be carried. So he'd been carried for the 2 days to get to the hospital. And it turned out his village was a very small one, just consisting of 3 households. The father of this boy and his 2 brothers, so his 2 uncles, if you like. And the father told us that over the last couple of years, one by one, members of this small village were succumbing to a disease that was characterized by a cough, a chronic cough, night sweats, losing weight, and one by one, unfortunately, these villagers were dying. Now, I don't know how familiar you are with medicine, but those, at least with a bit of training, would recognize those as the very classical symptoms of tuberculosis. But they didn't know what was going on. That they consulted the local healer, the Dharmi Jankri, as it would be called in Nepali, and asked for his advice. And he kind of went through the rituals and sacrifices and what have you, and clearly those things didn't work. Now, I want to make it clear I'm not dismissing the role of traditional healers, and in another role in Nepal, I spent a bit of time training and working with these people, because they are the eyes and ears out in the villages and are well placed to spot signs of serious illness. But on this occasion, he didn't recognize that this was a serious illness that required treatment. And in fact, when this little boy became ill, he told the father, if you take the boy to a hospital, he will surely die. But the lad's father thought, well, the rest of my family have died. My wife's died, and my brothers have died. I've got nothing to lose. So he took him to hospital. We diagnosed him with TB and started him on treatment, and he responded very well. But the village was not only remote, there were not only no other health services there, the family were subsistence farmers, so very, very poor, just relying on what they could grow within the land that they had available. That they were illiterate, so they couldn't kind of read and write. So even if there was sort of health information around, they couldn't have accessed it very easily. So I reflected on this and kind of had a light bulb moment that although tuberculosis had been the immediate cause of this lad's predicament, there were some causes of that cause, and it was the inaccessibility of the village. It was the remoteness of health services. It was the fact that the family were illiterate, that they were living pretty much near the poverty line. They didn't have the resources in order to access the help that they needed. So that made me think that, you know, these things are really important in terms of health and well-being, really important in terms of improving the health of communities. So I finished my 6 months there and came back to work in Newcastle, and I was just kind of reminded by that experience of another woman that I'd seen in working in Newcastle, actually when I was a house officer at Newcastle General Hospital, which was known at the time as the workhouse because it was previously a workhouse in Victorian times. Thoroughly modernised now and quite different to how it was then, but it still had that kind of Victorian feel. And I remember looking after this woman called Margaret, and she was in her 60s, and she had end-stage chronic obstructive lung disease. And I was called to see her in the middle of the night and just sat with her and held her hand as she literally breathed her last. Now, a 60-year-old is not old, and certainly not an age who should be dying of chronic lung disease. But this had been caused by the fact that Margaret had been a smoker for more than 40 years. But again, as I kind of thought about Margaret's story, she hadn't come from the well-to-do part of Newcastle. She came from the west end of Newcastle, the poorer part. She hadn't completed education at school. She didn't have a good job. She came from a society where smoking was the norm. In her community, the majority of adults would have been smokers when she started smoking. So again, that kind of realization that prevention was much better than cure, but prevention required us to address some of those determinants of, in this case, smoking behavior, those determinants of ill health. So that's what got me into public health, those kind of two light bulb experiences where you realize that there's only so much you can do by providing treatment, particularly towards the end stage of a disease process, and how much better it is to act early and prevent illness from happening in the first place. But in order to do that, we need to influence the conditions in which people live. So public health then is defined as that science and art of preventing disease, prolonging life and promoting health and well-being through the organised efforts of society. That there is a science to it, there is an evidence base, a robust evidence base around the interventions that we try to put in place. But because it does require the organised efforts of society, there's an art to it as well. There's a kind of a leadership that's required if we're to make these things happen and to make a difference. It is a very broad agenda. That's one of the things I love about it. You can be dealing with everything from tobacco to transport, children's health to climate change, violence to viruses, pretty much anything which directly and indirectly impacts on people's health and well-being. Viruses, of course, in the news over the last 2-3 years when we've been dealing with the COVID response, and we can talk a bit more about that later if people are interested in hearing more about that. But a simple way to think about it is that clinical interventions really relate to individuals. It's if you give somebody treatment for high blood pressure, for example, or diabetes, that's an individual level clinical intervention. Public health interventions can be thought about things which apply to populations, to groups of people rather than individuals. So that's public health, but I think it's really important that I just spend a few moments focusing on health inequalities, because we know that everybody does not enjoy the same level of health. There are these unfair and avoidable differences in people's health across the population and between specific groups. Now, I've just put a few figures down here. There's lots more that I could have put up there, but they are sobering, I would suggest. So if you are homeless and living on the street, your life expectancy is roughly half what it would be for somebody that's in a housing situation. So I think that's quite shocking. If you live in one of the more deprived areas, so I cover the northwest. If you're a woman in Blackpool, your healthy life expectancy is just barely 50 years. So you don't even reach retirement age before you start developing ill health and conditions which affect your life expectancy. In the most affluent parts of the country, that is 70 years. So a 20-year difference in healthy life expectancy depending on where you live. Asylum seekers, similarly, poor health. Those coming from certain ethnic groups similarly suffer poor health. Back to COVID again, COVID deaths in black men were considerably higher than those in white men during the first wave of COVID-19, and understanding those differences really important in terms of the response. And those with serious mental illness, 390% excess mortality compared to the average. So, really quite stark differences in people's health that it is important that we understand, because that then will need to guide the interventions that we put in place. Now, there's a bigger picture to all this, of course. So I felt it would be remiss if I didn't pick up on this, because I think this is really topical and going to be really important in terms of your careers wherever you end up. So this is a graphic just to try and explain that. So the smallest box there perhaps represents individual clinical interventions. The next circle out is public health, so that's at community level, population level. That's what I've just been trying to explain. Global health could be thought about those public health interventions in an international context where people face perhaps different barriers to achieving good health. One health can be thought about as not only human health, but also animal health and the sort of biosystem in which we live. And we know that increasingly we're seeing viruses that are hosted within pigs or chickens or whatever, and find some way of transferring to humans. And every now and again, one of those viruses will be able to replicate within humans, be transmitted between humans, and cause severe disease. And that's inevitably going to happen. So we will see another pandemic that takes that kind of route at some point. At the moment, none of us know quite where or how or when, but it will come at some point. So important that we understand that kind of One Health dynamic, not just thinking about human health, but also thinking about animal health. And then the biggest circle, of course, is planetary health, thinking about the environment in which we live and climate change. The figures today have been produced on the excess deaths that we saw during the heat wave in the summer. Nearly 3,000 people over the age of 65 died unexpectedly, above what we would have expected during the summer because of that hot weather. This winter, every winter we see excess mortality related to the cold weather, and this winter in particular, when people are worried about the cost of living and the cost of fuel and whether they can heat their houses, there's a real concern that we might see excess mortality associated with that. So really important that as public health people, we think about planetary health and the changes to our climate. Now, I'll talk in a minute about specialist public health training and specialist public health roles. But public health, I think, is something that every healthcare worker should be doing. Really important that everybody, I think, has an understanding of public health, because there aren't many public health specialists, frankly, and we cannot do everything. We need everybody contributing to making that fairer, equal, and healthier world. So maybe things about health protection that you can do, encouraging people to get immunized, for example, or practicing good hygiene, infection control measures to limit the spread of infection. There might be things that you can do to prevent illness from happening, falls prevention, public access defibrillators, being competent in basic cardiopulmonary resuscitation. Just some examples there, or promoting good health, promoting healthy behaviors, thinking about the well-being of your team and your staff. Making every contact count is a specific program which trains healthcare workers, and in fact anybody coming into contact with members of the public, to know how to go about having conversations around alcohol consumption, for example, or stopping smoking. Running health campaigns, or advising people on how they might stop smoking. Something that everybody can do. You don't need to be trained in public health to do these things. There is the potential to do more, though, and we need to make sure that our workforce in the NHS and the care system kind of understand the potential that they have to make these sort of interventions in the lives of their clients and residents and patients. But public health careers then, this is my final slide, and so it's a slightly fuzzy, so I'll just kind of talk through it a little bit. So the inner circle there just talks about public health careers and 4 domains in which people commonly work. So at the bottom there, there's academic public health. So you can train up through various fellowships and get the kind of research degrees that are required, the PhDs that are required for a career in academic public health, and that's a really important role in terms of generating some of that evidence, some of that science that I spoke about earlier, that then informs our public health practice. So there's academic public health roles. In the yellow there's health protection roles. Now in England, health protection is delivered by the UK Health Security Agency, which is a new agency specifically devoted to delivering on the health protection function, which is around communicable disease control principally, but also looking at environmental hazards and making sure that the population is safe from that. At the top, kind of orangey block there is around health improvement, and I'm now employed by the Office for Health Improvement and Disparities within the Department of Health and Social Care, which is taking forward that health improvement agenda, supporting people to be smoke-free, to understand better their alcohol consumption, how to be more physically active, how to eat more healthily, and so on. And then finally, healthcare public health. So I also have a joint role with NHS England in the Northwest, and I have a team within NHS England in the Northwest that looks at effective public health services, screening and immunisation services are within the NHS in England, and dental public health is also one of the functions. So we advise the NHS on the evidence around effective and efficient interventions. I'm the Senior Responsible Officer in the Northwest for our inequalities programme within the NHS, which includes the role of the NHS organisations as anchor institutions. So these are, you know, NHS hospitals, as you will understand, are big employers within the local area, and if they're recruiting from the local population in an equitable way, that's a real contribution to improving health in the long term. If they're procuring services from local providers that are paying a fair wage, again, that's another way in which they can contribute. So inequalities, I'm also the responsible officer for their prevention work and also for their work around the greener NHS, so helping the NHS to become more less carbon emitting to reach net zero. in line with the ambitions that the NHS have. So those are the kind of 4 domains in which people can work. Now, if you're in England and working within the local authority team, which is where directors of public health are appointed, you'll probably be covering 3, if not 4 of those roles. That you will have a health protection remit. You'll be doing things around improving health. You'll be liaising with the NHS locally, as well as very probably with your local academic public health department. Now, within those domains, you can kind of choose where you want to work. So the purple line on that kind of rainbow there is around the life course. So some people choose to do health improvement roles that focus on children and young people in those kind of early years. Other people choose healthcare, public health roles that focus on perhaps older people and aging healthily. So within each of those domains, there's a possibility to kind of think about particular segments of the population. And then on the outside, again, there's those kind of determinants of health. So from the left, genetics there. So there is a kind of subspecialty of public health genetics, just trying to understand how genetics affects the health of the population, access to healthcare, healthy and sustainable places, health behaviours, and social and economic factors. So a public health career offers the opportunity to work on those kind of issues, all with the aim of improving public health, the health of the population. Now, I've put some links there, which I'm more than happy for these slides to be shared. You can click on the links and go through to those sites for further information. But actually, if you just go and look on the Faculty of Public Health website, they have a tab on careers in public health, and a lot of detail there on how you can get into public health careers. If you think that specialty training is for you, by specialty training, I mean that after you've done your foundation training, you can train as a specialist in public health in the way that others might train as a pediatrician or a surgeon. It's the same 5-year, quite rigorous training program with postgraduate exams and so on. Public health specialty training differs from those other medical specialties, though, by being open to people that have come up through other routes. And this is one of the things I love about public health. You get to work with people that come from other disciplines. So you may have come up through a nursing route, allied health professional, other kind of healthcare route, or you may have come up through a completely different route, maybe been a geographer or a statistician or a journalist even, and all these skills really contribute, because if you're a statistician, that really helps to understand the data and the intelligence. If you're a journalist, that gives you great skills around how to communicate better with the population. So it's that richness of those that work in public health that I really enjoy. But more information on specialty training through the faculty website. It is very competitive. There are about 10 applications for every place, and that makes it one of the most competitive of the postgraduate specialty training programs. I think things like cardiothoracic surgery and neurosurgery might have a higher ratio, but that's because they have very few places. But as I said before, if you're passionate about it, don't let that put you off. If you think this is for you, you've got the heart for it, then go for it. But I think wherever you end up, I think it's well worth understanding some of these public health concepts and how you can contribute in whatever you are doing towards that fairer, more equal and healthier world. And I put a link down there, All Our Health. And it may be that you're, not yet embarked on your career, not quite sure what to do. Then this is a learning resource that you can kind of dip into. You have to register, but it's completely free. And you can go in there. There's all sorts of modules on, how you go around supporting somebody to stop smoking. There are things in there on climate change now, kind of roll in that. So all sorts of things, safeguarding, some really important concepts that it's important that everybody knows about. So that's well worth having a look about if you're thinking about getting into one of these professions. It's good to go and explore that so you become familiar with some of the concepts and some of the ideas that would go down very well at interview. I would suggest if you can demonstrate that you've done some of that prior learning. If you're in training at the minute and kind of exploring what sort of future career you might want, then again, just having a look around there and seeing what catches your eye and what interests you there. If you're already in a profession but just want to kind of broaden your thinking and competence around some of these issues, then there will be things in there for you. So I do highly commend that to you. So yes, that was all I was going to say. Thank you very much for listening to me today, and welcome any questions.
Thank you very much, Andrew. I hope you can hear me where you are. That was an absolutely fantastic presentation. Thank you so much for such a personal account of your own experiences, and also that really great overview of the role of public health in modern times. I'm sure many people at home who may have just heard about public health during COVID but didn't really understand the role that it played in the true span of the community that it covers may now have a better understanding. And as well, talking about your global experiences as well, to show, as you mentioned, that there is really just one health. So a question that we've got for you here, Andrew, is there is a cost of living crisis coming up in the near future. What role does public health play in that?
Yeah, a huge role actually, and we've been doing a lot of work with our Director of Public Health in the Northwest on this at the minute. So it's a number of levels. Yeah, so understanding the data and the intelligence on this. Some of our analysts have been looking at the housing stock in the Northwest and which households might be more vulnerable to the fuel cost increases that we're seeing at the minute, how that then correlates with what we know about people's income, what we know about poor health in these communities. So using that intelligence and that data to enable then local services to be able to target communities with support and with help. I've got somebody at the minute doing a bit of work around food insecurity. Again, just trying to understand what is the evidence base about how we can support people that might be struggling to find the money that they need to eat well during the winter. And also to do that in a culturally appropriate way, just kind of understanding the kind of food requirements of different populations within the Northwest. So again, kind of just thinking about that kind of from an inequalities angle as well. Working with our colleagues in the NHS around what this cost of living emergency might have implications for them in terms of their own staff and their own workforce, but also, and most importantly, the people that they're supporting and caring for, how can they better understand how to signpost people to other sources of help that's out there. So an awful lot of work going on at the minute, Yaz, around planning for winter, which we do every year, but this year particularly focusing on the cost of living emergency.
Thank you for that answer, Andrew. Truly covering a wide breadth again. There's definitely always a lot going on in public health, and that leads me well on to my next question. With so much involved in public health, sometimes it may be a bit overwhelming for people who are looking into getting involved in public health. To the young people watching today who want to gain some experience or find out more about public health, what's one small tip that you might give them if they're hearing you talk about, this, how much public health is doing?
Yeah, I mean, that's one of the great things about public health, the breadth of it, but it's also the downfall in that sometimes it can be difficult to prioritize what we do to the most important thing. But I think if you're a young person, just pick an issue that you feel excited about and passionate about. It might be climate change, it might be global health, it might be the health of young people, it might be something around mental health. Just pick one thing that you feel passionate about, and just do some exploring on the internet to find out a bit more about it. Consider, volunteering for a group within your own community that's perhaps doing some work on this. People are always looking for support and for help on these issues. So I would just that would be my top tip, just to find one thing. I think the other thing I just kind of mentioned, Yaz, is the importance of having a mentor. And certainly during my career, when I was at medical school, there was a professor of pediatrics who I kind of somehow latched onto, and he was very kind in just kind of advising me from time to time when I was kind of struggling a bit and needing to know what to do next. And when I was just kind of reflecting back as I was preparing for this talk, I was just thinking how I've benefited at different stages from different mentors, people that have kind of helped me and guided me along the way. So if you're a young person thinking about setting off on this journey, and if you can hook up with a local group and find somebody that's, prepared to mentor you a bit or just kind of guide you on that journey, I think you'd find that really helpful too.
Good morning everyone, and welcome to the National Health Careers Conference 2023.
Hi, my name is Nat.
Hi everyone, I'm Amy Robson. I'm the Deputy Director of Personalised Care at NHS England. I'm a physiotherapist by clinical profession and working in this strategy and non-clinical role in NHS England nationally.
Hi there, I'm Dr. Freddie. It's great to see so many of you here at the Health Careers Live Conference 2023.
It's always a delight to meet with you, and I hope today's session will be useful.
Maybe you're attending today thinking, okay, I know I want to do this job in the NHS. It might be that your eyes are open today to some other options as well that look really exciting to you. Or you might have joined thinking, I want to work in health, but I've no idea what I want to do. So, for you, this day is perfect.
Why is diversity in healthcare important? And I just want to touch on three main things that I think are really important when we think of diversity in healthcare.
We know that GPs look different to people now. People perceive GPs slightly differently. You mentioned earlier about how the pandemic has had a huge impact on how we operate. We see that our patients are becoming more and more complex in the way that they present.
We set ourselves a target to eliminate disproportionate referral and eliminate differential attainment in education.
To me, personalised care is both the middle of that continuum, as well as the ability to meet the person where they are in that moment of time.
It's always great to be able to kind of open people's eyes to the range of roles in the NHS and the range of routes in, because there is so much more than you might be aware of.
It really is inspiring to know that there are so many options to progress and to really put your passions across in healthcare. We're glad to announce that next year's conference, the National Health Careers Conference 2024, will take place on Friday the 5th of July next year. So please do keep an eye out over the next few months on our social media pages. Thank you very much for attending.
This session is on well-being, and we're joined by Professor Dave for this important session covering the importance of well-being in the NHS. Doctors in Distress was created to raise awareness on the value of medical professionals, health and well-being, and the need to care of those that care for us. So I'm just going to pass it to you, and you can start the session when you're ready.
Well, thanks everyone for inviting me. Thanks to Rajiv and team for organizing such a wonderful session. And if you give me 2 seconds, I'm going to try and start sharing my screen. So there we are. Hopefully, are you able to see my slides? If someone can just say yes to me.
Yes.
Okay. I won't be able to read the text box, so apologies for that. And that's my Twitter handle if anyone wants to tweet about the session. So I just wanted to start with where I started. And I think I started my journey in Grant Medical College in Mumbai, in India, which is one of the oldest medical schools. And as you can imagine, in a crowded city like Mumbai, it was quite an experience. An outpatients clinic would normally be full of about 150, 200 people. So early in the morning, people would crowd and start milling around. And very early on, I kind of realized that the level of joy that you got from actually helping other people. But what I also realized is that your science was only as good as it was we were able to use it to help other people. And so I think that whole idea of wanting to make things better for people is woven into the idea of medicine. And that is so ingrained, but I don't think we think as much about helping ourselves. And I think that bit of the kind of wiring just does not take place. And I think my talk is really about that today, is to see, well, how can we change that way of thinking? How can we start embedding it in the curriculum? And I think that's what we've been trying to do in Nottingham Medical School, where I support the undergraduate medical program in psychiatry. I think we've tried to make sure that awareness of not just about the mental health of our patients, but awareness of our own mental health and well-being is embedded in our training program. And that's what also I've tried to do in the international programs that I've been involved in. And this is the University Teaching Hospital in Lusaka in Zambia. And so, like I said, I think for me, I think the whole issue is that when we think about how do we make the best clinical decision, there are 3 elements there. So one is about patients, their ideas, beliefs, and concerns and expectations. Clearly, we all want to follow evidence-based practice. But the third element is that individual clinical expertise. And I think that individual ourselves is often the forgotten bit. I think we forget the need to look after ourselves. We forget the need to empower ourselves and to feel empowered so that we can actually help our patients and use our expertise to help our patients. And it's been a real bugbear for me that while we wouldn't allow anyone to enter a building site without a hard hat, yet we expect that in a profession like medicine or more widely in healthcare. Now, I might be referring to doctors today a lot and then say medicine, but I think the issues are very relevant to all healthcare professionals. So if there are people from other allied healthcare professions in the room today, I think what I say is very much relevant to you as well. Though the data probably has been collected more, and the research has probably been more available in the arena of undergraduate and postgraduate medical education. And so I feel that while we know that medicine will expose you to mortality, morbidity, and you will come across a whole range of distressing scenarios as a part of your working life, and so it's a working hazard. And yet I don't think that the equivalent of a hard hat has been built into our training. And so that's something I feel quite passionately and strongly about. And I think my involvement with Doctors in Distress is very much a manifestation of that. And I think what has happened as a consequence of that lack of early prevention and early resilience training is that most of us now, at the end of the working day, we feel like we're completely drained. And so my hope is to kind of, at the end of this talk, is to give you some pointers as to how do we move from that sense of being drained to feeling a bit more recharged. And I'm a marathon runner, and a couple of years ago, I ran the world's highest ultra marathon in Ladakh in the Himalayas. And for me, I think it's just a manifestation of the various kind of things that we need to do to keep ourselves well. So for me, it's running. For other people, it might be other pursuits, some within medicine, some maybe outside medicine. But I think it's important that we give ourselves time and space for that, because looking after ourselves is very, very, very vital, not just for ourselves, but for our patient care. And I think I'm going to illustrate that in the next few slides. I'm going to skip some of these slides. I think, but this is just to illustrate that lots of celebrities have come out in the open and talked about their mental health issues. So talking about mental health, I think, certainly has become a bit more easy. I think even probably a decade ago, there was a lot of stigma about mental health and anything to do with well-being. But I think things have changed now, and we've seen, celebrities like Stephen Fry and Deepika Padukone, who is a Bollywood actress, come and talk about their experience with mental illness. And I'm the Dean of the Royal College of Psychiatrists, and we've run programs in the past, and we've highlighted that the prevalence of mental illness is as high as 1 in 4. But I think what that 1 in 4 figure sometimes obscures is the fact that that figure is not true for everyone. And for some groups of population, so particularly we know that those who are economically deprived, or those who have had early life trauma or disadvantage, for them the rate is higher than 1 in 4. And similarly, what's not often realized, that for medical professionals and healthcare professionals, the rate is higher than 1 in 4. So we are actually more vulnerable to mental illness and mental health problems than the general population. And so if you feel free to guess. I can't see your answers, unfortunately, in the text box, but if you feel up to it, do put your answers in the text box. So I think people don't realize that the risk of this mental health problem starts very early on. So it starts in the undergraduate medical world itself. So we find the prevalence of depression or depressive symptoms in medical students is quite high. We're talking of almost 1 in 3, so it's 27%. So it's quite a significant number of students who report this. And how does that compare to other students of similar age adults? So if you compare medical students to because we all know that leaving home after sixth form and going to university is a time of stress. It's a difficult time, and so it's a stressful time, and that does have an impact on mental illness of all university going students. But is it that medical students are disproportionately affected? Yeah, the answer is yes. Actually, the rate in young adults of similar age is almost a third of that of medical students. So we know that medicine is a high-stakes profession. It is a high-intensity profession, high-intensity occupation. There are high-stakes exams regularly. The course is quite difficult. The amount of material that you have to absorb and retain is quite a lot. And all of that does have an impact on the way you perform. And then obviously you're also surrounded by people who have all done very well. So you are in a group where all of the people in that group are high achievers, and that also has consequences. So much so that the prevalence of suicidal ideation is also pretty high in medical students. Now, it's not super alarming, though. The figure can seem quite alarming. I mean, it just needs to be borne in mind that the prevalence of suicidal ideation in the general population is also around 5 to 10%. So it's a little bit higher, but still, I mean, something worth noting that people who have increased access, perhaps, to means of self-harm and suicide are then having a higher rate and proportion of suicidal ideation. So I think something to bear in mind. I think I certainly point this out to all medical educators and healthcare educators. And we've seen this happen in the real world. So I don't know whether any of you've seen this documentary on Victoria Derbyshire, talking about Sophie Spooner. And in fact, Sophie's father is one of the trustees with Doctors in Distress, and Sophie's mother is also very much involved in supporting medical professionals and their mental health. So they're very much aware that that this is a problem that needs to be addressed. And GMC ordered a review, asked Louis Appleby, who has led the confidential inquiries in suicides and homicides in the country for a long time. They asked him to look at medical professionals, and he reviewed the death of 38 professionals. And I think clearly, I think the fact that you are referred to the GMC becomes a significant factor. There are other factors like being an international medical graduate, or having a mental illness. So there are a certain set of risk factors that we know can predict the risk of suicide. And I think if we get better at identifying those risk factors and working with people earlier on, I think we can prevent this. But this is probably not confined to the UK alone. I think if you look at the figures in the US, it's almost 1 doctor a day, and this is just doctors. And if you start adding healthcare professionals, then the number is quite significant. So over the last 5 to 10 years, this has now been highlighted as a real problem that we need to deal with. Now, having said that, I find, and I think research shows that medical students who actually disclose mental illness still report that they don't get the amount of support they need. And so the answer to this question is a shocking over 80%. So over 80% of the medical students with mental illness do not get the kind of support they would want. And so basically they report that they just don't feel supported. Now that is a shocking figure. And I think that is something that we as a group of healthcare professionals and there's some responsibility, I guess, on all of us who are in the healthcare profession to address. What is the percentage of medical students with the diagnosis of depression seeking help? Again, it is quite low, and which is particularly sad because the outcome rates of people who do seek help are very good. So we know that that if people actually seek help early enough, then you are seeing that the response rates are in the region of 70 to 80%, which is fantastic. I think, and that's just for depression and anxiety. But I think even when you include things like substance misuse, which doesn't always enjoy a very good prognosis and doesn't always enjoy very good response rates, you find that medics and medical students, when they have sought help early for the substance misuse problems, the response rates are touching 90% and over. So the real moral of the story here is that seek help early. Don't wait, don't delay. The earlier you identify the problem and the earlier you seek help, the more quickly you're likely to resolve it and then get back to normal working. And there are a whole set of reasons why people don't seek help early enough and then don't disclose early. We know that that female students are more likely to disclose problems early. Graduate students and more older students are likely to do that. People who have had to take time off sick, so at the more the severe end of mental illness. So there is some kind of a trend there, but there are many other factors that stop us from disclosing. And again, researchers have looked into this as to why do we not seek help. And I guess what I started off with is one of the main issues, that we see ourselves as help providers and not as help seekers. And I think that is a big barrier. There's almost that us and them wall that we erect between ourselves and our patients, that we are not the same as our patients. And the reality is that we are like our patients. We are not some different species. We come from the same population, and we reflect that, and we represent them, and we are them. And so the kind of problems that we see in the general population also occur in the medical world and in the medical population. But there's a fear that if you get the label of mental illness, then that gets you involved. You might be referred to the GMC, or you get referred for, internal processes. There's a fear of stigma. There's a fear of discrimination. There's a fear that your colleagues will view you differently, and then your patients will view you differently. I think a lot of my colleagues who have sought help have said that they particularly worry about patients not wanting to be treated by somebody who has mental illness. And I don't dismiss all these concerns. I feel that these are real fears, but unless we confront them, unless we deal with them, not just at an individual level, but as a group, as a profession, we're not going to make progress. And so there are a whole lot of reasons. And I guess at some level, it's also a pessimistic view that somehow, what's the point in seeking help? It's not going to be, and I've had colleagues who've said this to me themselves, that was the point of seeking help. It's not going to make things better. I need to get out of it myself. I need to sort things out. And yet, we know that logically that's not correct. That if you need to fix your if you've got an electrical problem in the house, or if your dishwasher needs fixing, then you call the expert, right? You're not going to try and do it yourself. If there's something, if you want to travel from, Birmingham to London, you don't say, I need to walk there myself because I need to do it by myself. I don't need to rely on others. You know that it's far more sensible to take the train or the bus or the car. And yet, I think when it comes to mental health, we somehow feel that I need to do it by myself. I can't ask an expert. I can't seek help. And I think that delay in seeking help is what ends up causing problems a lot of the times. Like I've said, there's good evidence to show that the earlier you seek help, the better you're likely to get, and the more likely you're likely to get better. And all of this has an impact not just on your health, but it has an impact on the entire system. If you have people who are turning up to work but are not fully there, what's known as presenteeism, it affects the productivity at work. It affects the morale at work. Overall recruitment and retention rate gets affected. And we're certainly seeing that in the last decade, the number of doctors and healthcare professionals reporting stress and burnout has risen significantly. We are seeing more and more people now reporting mental illness and then taking time off because of mental illness. So I think these issues are relevant. And I put up this slide because this was an award we won for our program, which we've led in the undergraduate medical student education in Nottingham for over 13 years now. And basically the program is of involving patients in teaching. So we have a set of about 50 patient educators who come in and share their stories, but not just share their stories, they also are involved in training our students. So they give feedback to our students about how they should interview them, or how they should talk to patients, and how they should communicate with them. And we found that we've seen over the years that consistently this program gets the highest feedback of all the things that we do, not just in psychiatry, but in medicine. And I think the reason why it's so popular is because there's the direct contact with an individual and an individual story. And so now we've extended it to doctors with lived experience. So we invite doctors with lived experience to come and talk about their experience of having had mental illness while at work. And we found that the response to that has been stunning. You know, people have been able to suddenly feel that they are able to share, that they do feel stressed at work, that they do feel that they're not cut out for medicine, that medicine is stressing them out, or the thought of turning up to work is filling them with anxiety and dread. And you know, you are surprised to know that you're not alone. This is a feeling that's shared by many other professionals. In fact, my psychiatric trainees committee in the Royal College of Psychiatrists is running a series of podcasts called You're Not Alone. So do Google that and listen to that. I mean, there are a set of inspiring podcasts, and I think you'll find that resource quite helpful. And so this Dr. 1 in 4 program has been actually quite a revolutionary program. We've been trying to promote a culture where doctors and students feel empowered to ask for help earlier, and that we move away from the idea that somehow acknowledging your mental illness is a sign of professional weakness. And so our outcomes are fairly straightforward. We want people, first of all, to know that actually the incidence of mental illness in doctors is quite high. You know, so you might think that as doctors we are immune, but the reality is the opposite. We, like I said right at the beginning, we are a bit more vulnerable than the general population. And we want our doctors and medical students to get that first-hand perspective, that, well, what does it mean to actually have mental illness? What do you do when your GPA asks you the question? What kind of forms do you fill in if you want to get help from your clinical director or your managing medical director? How do you deal with the awkwardness from colleagues? Because this is true, right? That talking about that mental illness is awkward, and people do not know how to approach you if you say that you're depressed or anxious. I think I had this issue, you know, at the beginning of last year. I developed an ankle, a fairly severe ankle sprain. So I was on crutches, and while I was walking around the hospital corridors on my crutches, at least about 50 people would have stopped me and asked me, well, what happened? How are you doing? And just a couple of months earlier, I'd written to my team saying that, like, I'm feeling a bit upset because I've lost my mentor who died quite suddenly. And out of a team of 70, only 2 people responded. And I think that just shows that, and I'm sure a lot of you in the audience must have felt the same thing, that if you are exposed to someone's grief, someone's sadness, then you don't quite know what to say or how to say it. And yet, I think we are in the healthcare profession, right? We are trained to ask difficult questions. We are trained so that in the middle of the night, wherever you're working, you can ask a whole lot of difficult questions about people's personal lives, about their personal medical history, embarrassing questions about their sexual history, embarrassing questions about their mental health, embarrassing questions about their, you know, whether you are smoking cannabis or other drugs. And we expect people to disclose all of that to us. So I think we know how to learn to do this. So I think having those awkward conversations at work with our colleagues is something we can get over. You know, I think we can teach ourselves how to do it. And I want us to think about how do we do that. And I want us to think about how and where to access support. And I don't know whether you all in the audience today know where would you direct your colleagues or yourself, indeed, if you needed help. And I'm not sure whether we kind of always have that information. And yet help is available, and I will share some of those resources. So clearly, Doctors in Distress is one such resource. We conduct a whole group of programs for people who are in distress. And our motto is quite simple. Our mission is quite simple. We want to help reduce suicides within the medical profession. The charity was founded by Amandeep, who lost his brother, a cardiologist, who ended his life by suicide. And he was moved enough to try and set this up, and his story is so inspirational and so you know, incredibly humbling. And I feel there's always that little bit that we can do. You know, I think, well, supporting charities financially is one thing, but also contribute with our time and energy and resource. But we're not the only one. There's Doctor Support Network, which is a peer support for UK-based medics who have undergone mental health problems themselves. People might have heard of wounded healer Ahmed Ankir, Caroline Walker, who runs the Joyful Doctor and also runs the Tea and Empathy group on Facebook. So there are a whole lot of informal and formal supporting mechanisms. But if you are in work or training, make sure you tell your training supervisor, your clinical or your educational supervisor, your deanery will have a professional support unit and they can help. Your employer, your trust or health board will have some kind of a support for their employers. BMA offers support, and then there are the generic supports, and we shouldn't forget them. So there is across the country, there is integrated access to psychological therapy, so counseling services that are available through your GP, but also directly you can refer to them yourself. So if you Google IAPT, that's integrated access to psychological therapy in your area, you can access that. For doctors in England and Wales, we have the practitioner health program, and then there are similar programs in Wales and Scotland, though not in Northern Ireland at the moment, but most of the places have them. My own college, psychiatry, Royal College Psychiatrists, we run the psychiatrist support service, and there are similar services run by surgeons. And then there are other support programs for doctors with substance misuse problems, for doctors who have been suspended. So irrespective of where you are in your training or what grade you are or what kind of problem you have, you will find that there is an avenue of support. And I think what we find is that if you do actually seek the support, then the outcomes are much better. So I want to end on this note by saying that we are all in this together, and then together we can wipe out the stigma surrounding mental health. And I'll just briefly tell you the story, and I don't know whether you all have heard of the story. This is from Professor Steve Robson, who became the president of the Royal College of Obstetrics and Gynecologists in Australia and New Zealand. And they've been running Australia and New Zealand to address this problem that I've been talking about. They've been running a program called Crazy Socks Day, where doctors wear crazy socks and just highlight that doctors have mental health problems too. And to support that, Steve Robson wrote a little blog talking about his story, about how when he was a trainee, he tried to kill himself. And he talked about how the only reason why he'd stopped was because some person, he didn't know who, came in and knocked on the door and say, "I know you are in there," and just that intervention stopped them from killing themselves. And now they were the president of this college. And amazingly, Dr. Kate Tree read the story and then responded saying that, "Look, Steve, I had no idea that it was you, and then that you thought it was you, that you thought that it was just plain good luck, and that we knew what was going on with you, but we just didn't know how to intervene, how to help, and that I hope I would do better now." And I think that's my message to you, that let us not shy away from intervening. If you see a colleague in distress, go and help, offer something. If you yourself are in distress, then seek help. And so my take-home points are that remember that there is this continuum of well-being. Some of us will be stressed, but some of us will be having severe mental illness. And I think severe mental illness can actually be quite, damaging to one's health, and occasionally can lead to death. And so we need to take it seriously. But let's not underestimate the power of conversations. We can intervene, we can reach out, and as colleagues, we can be human. You don't have to be a psychiatrist or a trained professional to just reach out to someone else, just as one human being would do to another, and then ask out for them, saying, "Well, how are you? I mean, would you like to have a cup of tea? Would you like to talk about how you're feeling?" And finally, just make sure you know where and how you would seek help, and program it in your phone so that I've listed quite a lot of resources. They are available to you. So make sure you use them, and they are available to you very easily. So I'm going to stop there. You've got my contact details there, and for doctors in distress. And it's a charity, like I said, it relies on people's donations, etc. So feel free to go and visit the page and connect with us and support the charity. Thank you.
Thank you very much for your presentation. I certainly really enjoyed listening in.
Okay, I don't think I see any questions in the chat box, so
Yes, nor do I. So I think we can end the session here.
take care.
Thank you very much again.
Bye.
Good morning, everyone, and welcome to the National Health Careers Conference 2023.
Hi, my name is Nat.
Hi everyone, I'm Amy Robson. I'm the Deputy Director of Personalised Care at NHS England. I'm a physiotherapist by clinical profession and working in this strategy and non-clinical role in NHS England nationally.
Hi there, I'm Dr. Freddie. It's great to see so many of you here at the Health Careers Live Conference 2023.
It's always a delight to meet with you, and I hope today's session will be useful.
Maybe you're attending today thinking, okay, I know I want to do this job in the NHS. It might be that your eyes are open today to some other options as well that look really exciting to you. Or you might have joined thinking, I want to work in health, but I've no idea what I want to do. So, for you, this day is perfect.
Why is diversity in healthcare important? And I just want to touch on three main things that I think are really important when we think of diversity in healthcare.
We know that GPs look different to people now. People perceive GPs slightly differently. You mentioned earlier about how the pandemic has had a huge impact on how we operate. We see that our patients are becoming more and more complex in the way that they present.
We set ourselves a target to eliminate disproportionate referral and eliminate differential attainment in education.
To me, personalised care is both the middle of that continuum as well as the ability to meet the person where they are in that moment of time.
It's always great to be able to kind of open people's eyes to the range of roles in the NHS and the range of routes in, because there is so much more than you might be aware of.
It really is inspiring to know that there are so many options to progress and to really put your passions across in healthcare. We're glad to announce that next year's conference, the National Health Careers Conference 2024, will take place on Friday the 5th of July next year. So please do keep an eye out over the next few months on our social media pages. Thank you very much for attending.
So after a fantastic set of speakers this afternoon, thank you so much for joining the National Health Careers Conference 2024. We can't wait to share further events with you to support your health career development. Later in the year, we will have a conference focused on supporting portfolio careers, and of course the National Health Careers Conference will return next year in July. We'd like to thank our partners, including the General Medical Council, the Royal College of Psychiatrists, NHS England, and of course Becoming a Doctor. All that remains for me to say is have a lovely Friday evening and a restful weekend. Goodbye.